like to call the September 2020 Services meeting to order. Do we have a motion to approve the agenda?
Yes.
Mr. Fay and Mr. Forsyth, all in favor?
Aye.
Opposed? Carried. We have a motion to approve the August Service Committee meeting minutes.
So moved.
So moved by Mr. Larry Denisha and seconded by Rita Kern. And any discussion? Okay. Anyone is all in favor?
Aye.
Opposed? Carried. Okay, we're going to go on to the COVID update will be given by Ms. McGuire tonight. I don't think Dr. Wilson or Dr. Williams will be available. So with that, would we like to go forward with the?
Yep, she's just now taking the screen.
Do we have Dana there?
Yes, you do.
Okay, Dana. You're welcome to start your update, Dana.
Okay, thank you very much. So currently we have 316 cases with nobody in the hospital. We are monitoring just over 10 people. 301 have completed the isolation process. We're still at a 4 for the death mark. And again, these are the phone numbers for the testing site. So you must call to make an appointment before you can go. And you should self-isolate after you're tested until you get the results. So if you have any questions, you can give our department a call. So I kind of show this, and now we've had 6 months just of the response, and we're just kind of coming up on the 26th week. And so you can see that each month I list just how many cases we've had, how many of hospitalizations, if we had a death during that month, and then just the number of people who have been in quarantine. So keep in mind, people in quarantine are those who have come in contact with a positive, or the precautionary quarantines are those who have been to a state that is under the advisory. So you can see that we're starting to come down on the quarantines as well. I've showed this slide before, and I'm starting to prepare a few graphs to show trends for the types of the cases that we've gotten. So hopefully at the next meeting, instead of just listing this as a text, I'll be able to show what we've seen for like the types of cases when people got tested just due to a screening, that they were like an essential worker, that they were someone who went out of state, if they're from a college or a school. So I'm just starting to look at that kind of data. But on this slide, it does show a comparison for the months this summer of where we were on the first of that date with cases, with hospitalizations, with how many have went through the isolation process, and then how many deaths like we were at the first of the month. For each of the months, you can see just how many new cases. So we went from 12 to 40, and I think that says 15. I got to move my face. Yep. And so you can see that we've kind of went just up and down. So now I'll move forward to the current month. So on the 1st of September, we had 273 with 3 hospitalizations, and we've currently had 44 cases since the 1st of the month. 25 of those cases have been people with symptoms, and the type of cases or why people got tested and found out that they had just a positive result are still due to medical procedures just needing to be screened. If they're an essential worker, so that's mainly the nursing home staff. colleges, and so far this month, we've had 3 cases that could have been a student or a staff member. We've had a major cluster, and I do have a graphic to show about that. And that's been due to a workplace and some of the gatherings, just whether it's at an institution or just people just kind of getting just together. And with regard to the cluster we most recently had this month, we've had 24 individuals due to that cluster, and in total there were 28. We've had some school now cases. We've had 10 so far this month, and keep in note that could be a staff member, it could be a student, and this might be different from what the schools are reporting because they didn't start their kind of daily reporting until the first day of school. We've also seen a lot of cases that spread amongst like family members. So first one person is positive, and then it moves on to the rest of the family members. Here is the cases that we've seen just on a daily basis. And this is a great graphic just to see kind of how things have moved. So you can see the cluster really peaked during the first week of September, and we're just starting to come back down. And here is that graphic for the cluster that we have. So you can see by this picture, we have 2 main groups in the cluster, and the colors, when they are kind of deeper, that's the first part of the case. And as the cases grew based on their association, there's like a secondary and like a tertiary. And if they're kind of polka dotted or kind of shaded, that's just a family member. If there's a solid line between the dots, that we know for sure is a straight kind of link. If there's a dotted line, we're still trying to make just some of the connections. And that peach colored one, we think it's part of the cluster, but we're still kind of wondering. So we've started to map out these things so we can try to make links between the cases and try to make sure that we've captured kind of everyone. For weekly cases, we report from Wednesday to Tuesday, and so far we've had 9 this week, but there's just one more day in that kind of week that we do. So we are starting to come down on a weekly basis. And for a daily average, we're just over 1 at like 1.3. So we've really come down 2 since that first week in September. I always report by age, and it's the 3 groups that are still the highest. I do have a sideways arrow in that second group. They're starting to rise a little bit more, so I just want to be watchful just of that. The average age of the cases this past week is 32 years. We've stayed really constant by sex. It's still about 54% being female. And here's the graphic of who we have in isolation and quarantine. That first number is active isolation. That's who we monitor on a daily basis via a text or a phone call because they have tested positive. That next group at the 138, those are the people who have been a contact to a positive. And that 128 is the precautionary quarantines. So most of those people are in quarantine due to the travel advisory. We've seen now just over 4,000 people through the isolation and the quarantine process. Last week when they updated the states, because they do just every Tuesday, these are the states and the territories. There was 6 that came off and 1 that went on, and I believe that was Puerto Rico. And so there'll be an update just in the morning. So as some updates as they relate to COVID and some of the procedures we've had to change in the department. Since school has just started for the last 2 weeks, we've been working with them, taking a lot of phone calls, trying to help them to understand if a student is ill at school, if they should go home, and then when they can return. The schools have had to start doing just kind of like a daily kind of a report to the state. And so we do help to provide information just into that. We just had a meeting with the state today. We will have a school specialist. And so this person will be someone who works kind of in between our department and all of the schools just in the county. So just helping us with positive cases, with the reporting, helping to understand when kids can return to school. So if they need to see their doctor, if they need a test, if they should just stay home for a certain amount of time. And so that person will just be nice to be that in-between person. We have done some school vaccinations. Kids still need to be vaccinated, whether they're on site or in an online mode. Last week, our department did just over 75 kids. We still do have just about 100 more kids that we will do vaccinations for so that they can continue to go to school. We do continue to meet with the 4 colleges. We talk about just the management. They're all doing testing just on a regular basis. We hear those kind of results. We talk about the cases that we've had, share that information between the colleges, and just try to make the process just a little bit faster. And now that we have K-12 on board, we've talked to schools as well, and just knowing that we have like a seating chart has been very important when there is a case, just to know just how many students just around that positive person might have to go into the quarantine process. So like I said, with K-12, they have to do just a reporting each day to the state. So do the colleges. There is a dashboard on the New York State website for the schools, and I believe the college one will be starting soon, just if it's not up yet. And we do have kind of good conversations back and forth with the colleges and the schools. So we are just able to verify when we do just have a case there. We had our second rabies clinic last Tuesday, and we've started a new process. So it's kind of like a drive-through type. So we no longer have people come in large groups just with their animals. And we've gotten great feedback that we should have been doing this kind of all along. It's been nice. Just the animals stay calm. It runs very smoothly. So that's just one of the processes that we've been able to change, or that we've had to, that has worked really well. We are working on doing the same sort of kind of like a setup for like a drive-through to do the flu vaccinations for the county employees as well. So that will be coming up. Just as a reminder, I haven't shown this slide in a while, but we do a dashboard on a weekly basis. This puts the maps on there, and then the stats of kind of the cases by week and who's in isolation and in quarantine. And then on the back side of this is all of the resources that you may need to go to. So it has all of the New York sites for the phases, for the employers, just anything that you would need to know. And so, but if you do have questions, you can call our office as well. And if you have not been getting this, just let us know, because we can send this to you too. Like I always say, these are still the 5 things that we're trying to push: to wear a mask, particularly when you're not with your household, to social distance, wash your hands and be careful not to touch your face, to stay sick and really know just how you feel, like on a daily basis, on whether you should go to school, on whether you should go to work, and to stay local. And that is all I have for an update this evening. And if there's any questions, I can take those now.
Mr. Denisha.
Thanks, Mr. Chairman. Dan, I do have I guess it's a comment more than a question. You list 4 colleges. Actually, we have 5 in St. Lawrence County. We've got St. Lawrence University, of course, SUNY Canton, SUNY Potsdam, Clarkson, but we also have the Ranger School in Wanakena.
Yes, we do. And I don't have an update for what they're doing. I will try to have that for the next meeting.
Thank you very much.
Any other questions, Dana?
I have a question, but I don't think you could see me.
Sounds like Ms. Haggard, go ahead.
Okay.
Thank you, Mr. Chairman. Dr. McGuire, I know that many health professionals are recommending people get flu shots. And my understanding is that many of the local pharmacies are already out of the over 65 flu shot. And I don't know what the supply is on the regular flu shot. Do you have any information about that?
I don't. I can see if I can get any information on the supply, and then I can get back to you.
Any further questions? Thank you, Dana. While you're here, Dana, we might get into the resolutions.
Okay.
Resolution authorizing the chair to sign a contract with Health Research Incorporated for epidemiology and laboratory capacity, COVID-19 enhanced detection, and modifying the 2020 budget for the Public Health Department. We have a motion. Mr. Perkins and Rita Kern. Go ahead, Dana.
Okay. So this is to sign a contract. We were just awarded $308,000. I'd like to say that in the third whereas there is an error in the date. It should be June 30, 2022. And this funding can be used really for case investigation and contact tracing. So we are just starting to hire some of the temporary staff to do both of those kind of activities. It is just helping to pay for the overtime in our department and also for the other county departments that we have just taking on this work as well.
Any questions? All in favor?
Aye.
Opposed? Carried. Thank you, Dana. Second resolution for you, Dana, is proclaiming October 25th, through the 31st, 2020 as National Lead Poisoning Prevention Week. Do we have a motion? Rita Kern, Mr. Denisha, seconds. Go ahead, Dana.
Okay. We just like to recognize this week. This fits in with the lead, just the program we have that monitors kids, make sure that kids years 1 and 2 get a test. And it also will help this year, the grant that we have just working on the HUD program to do the rehab for the homes as well.
Okay, any questions? No questions? All in favor?
Aye.
Opposed? Carried. We have another resolution authorizing the chair to sign contracts with contractors, subcontractors, and consultants for opioid epidemic grant funding and modifying the 2020 budget for the Public Health Department. Do we have a motion?
Right here.
Mr. Burke and Ms. Kern, seconds. Go ahead, Dana.
Yep. So this is the second year that we've received the $72,000. It's the third year we've had the grant, and we've really had to modify some of the activities that we'd like to do just because of the virus. And we are doing a lot of, there's going to be some of the radio, just PSAs. We're going to have some of the PSAs on YouTube, and I believe on, I think it's called, it's called ABC 50. And so we had someone just come in and do a presentation like about a year ago. He's going to do those. We are doing a bus wrap to let people know where to get Narcan training. And we've been working with all the stakeholders, and we still have MAT training that's going to go on. So that is so that that you can provide the treatment when someone has an opioid disorder. And we're just doing all of these things now, like via the web. But we continue to meet just as a coalition, and all of these activities have been pretty strong in the last month.
Any questions, Dan? No questions? Okay, all in favor?
Aye.
Opposed? Carried. Thank you, Dana.
Thank you.
The next part of our agenda has to do with the community service presentations. And I would like to suggest, and I'm looking for okay approval to run this meeting where we would, because of the time involved here tonight, we've got a couple of meetings, and I think this could be a lengthy presentation process possibly, and there's 3 presentations to be given. Therefore, I would like to see each member of the legislature down to maybe 2 questions, maybe 3. Is there any objections to that format to run the meeting? Mr. Burke? I'm surprised, Mr. Burke. Go ahead, Mr. Burke. Go ahead, Mr. Burke. I can't hear you.
People are willing to yield their time for other people to have the questions.
I suppose that would be in order, yes, if they're ready, if they're willing to yield their time.
I'd be willing.
I guess, what's that? You feel, what, Ms. Haggard, go ahead.
Thank you, Mr. Chairman. Should Mr. Burke run over, I'd be more than willing to yield my time to him to ask questions he seems to want to ask tonight.
Okay. I don't see any problem. Mr. Lightfoot?
I would be against that. All it does is give one person who wants to accept yielded time the floor forever. And I think it's an unwise move to allow that. I think a couple of questions from, or 3, whatever you decide, is more than adequate, given the number of people that may want to address this board. And I wouldn't limit it to just legislators. I would limit that to everybody that, may be on this Zoom meeting. I just think opening it up to, it could go ad infinitum, but I don't see that. That's my feeling. I would go together.
Okay. Do we want to have a raise of hands of, yeah, that's what we're going to do. We're going to have a raise of hands of the people who feel that the 3 questions is enough.
Point of order.
Public.
Point of order.
Yes, what's point of order?
Point of
Yes, go
order
ahead, Mr.
is
Burke.
we're, Mr. Chair, we're governed by Robert's rules.
Yes.
And Robert's rules has a specific formula for closing a discussion, and it's not limited to 1 or 2 questions. If we need a reminder about what Robert's rules said, perhaps somebody could enlighten the chair.
I was simply suggesting that people could have a hands vote on how many questions we wanted to be asking tonight in this, so it doesn't go on all night long. So it's not like I made a rule and we're going to go with it. I'm looking for some advice from the members, and that's what's happening. Go ahead, Mr. Perkins. Excuse me, Mr. Perkins over there. Go ahead, Tony.
Yes, John's spoken very correctly. it's not a matter of what the chair wants or what the legislature votes for in a majority, is we're governed by Robert's rules. And I think, as he said, if we need our county attorney to indicate what we need to do under Robert's rules, then so be it.
Go ahead, Mr. Attorney.
You'll give me just a second, please.
Okay, I'll tell you the process that I went through before I reached the conclusion that I did. I'm definitely open to suggestions should you perceive that I've gotten the answer incorrectly. However, I reviewed the rules of procedure that are adopted annually by the Board of Legislature. The rules of procedure actually reference that unless it's specifically spoken to within the rules of procedure, that we default to Robert's rules as providing the answer. On Robert's rules, under the title Debate Committee of the Whole, which this body is acting tonight as a committee of the whole, specifically states in page 516 of the Rules of Order, in debate on motions to adopt or amend, unless a limit is prescribed by the Assembly before it goes into committee of the whole as explained below, each member can speak an unlimited number of times under the rules given in the first paragraph of the section. If the committee of the whole wishes action to be taken which requires the adoption of any motion other than those that are in the order of the committee as listed above, it must vote to rise and report a recommendation that the Assembly takes the desired action. As a committee, as applied to committees in general, the word rise simply describes the parliamentary step of ceasing to function as a committee preparatory to making a report, as stated on page 484. The motion to rise is not used in ordinary standing committees, and in ordinary special committees, it is used only when the committee is ready to make its final report and go out of existence. In a committee as a whole, on the other hand, the word rise applies to any case of the committee's returning to the status of the Assembly, whether it is expected to be temporary or permanent. Among the consequences of the rules stated in the preceding paragraph are the following. The committee of the whole cannot appoint subcommittees or refer to a matter to another ordinary committee. An appeal from the decision of the chair must be voted on directly, since it cannot be postponed or laid on the table in the committee. The only way for debate to be closed or limited in the committee is for the Assembly to specify such conditions before going into the committee of the whole. If the committee develops a desire to have debate limited, it can only do so by rising and requesting the Assembly to impose the desired limit as explained below. If debate has been closed at a particular time by order of the assembly, the committee does not have the power, even by unanimous consent, to extend the time.
So summarize it, Steve.
Thank you. The provision indicates that the committee of the whole, which you are, have the ability to establish ground rules before going into an item. Once the item is started, the committee of the whole, no matter how many people vote in favor of it, cannot stop it and convert it back to a situation. In the absence of voting in favor of a limit on debate, there is unlimited debate or a limited discussion on any item on the agenda. So theoretically, right now, you as the committee of the whole, prior to taking up the issue, may establish parameters by which debate will occur. Outside of that, if the debate begins or if the item begins on the agenda, you are past your point of being able to raise the issue and limit the debate other than through a proper motion to limit debate, as Tony indicated, and as John indicated.
So, question?
Yes, go ahead, Mr. Burke.
So what you're saying, Steve, is that if it's brought up on a particular topic, debate can be limited by a majority rule, and we aren't subject to the rules that we voted on in January?
No, I believe you are subject to the rules that you voted on in January. The problem that I'm having with the rules that you voted on in January is that the rules that were voted on in January do not specifically address a situation in which you wish to limit debate on a specific topic on an agenda. In the absence of having specific language within the rules of procedure direct that anything not directly or specifically addressed within the rules of procedure defaults to Robert's rules. So I defaulted to Robert's rules, which stated on pages 516 to 517 that it is possible to theoretically limit debate on a subject matter as long as debate has not started on that subject matter yet by allowing the committee itself to establish the parameters. It does not speak there on page 516 or 517 to the nature of a vote. It speaks to the committee being able to reach an agreement.
How does that reconcile with Robert's rules that state that a debate can only be shut down by a 2/3 vote?
I'm not trying to shut anything down.
You certainly are trying to shut it down. You want to limit it to 1 or 2 questions. So anytime there's a political agenda that you want to push through, you limit debate. What a clever idea.
Mr. Burke, if I may just read the relevant provision that I cited to before. It's on page 517 of Robert's rules. The only way for debate to be closed or limited in the committee is for the assembly to specify such conditions before going into the committee of the whole. If the committee develops a desire to have debate limited, it can only do so by rising and requesting the assembly to impose the desired limits as explained.
And that wasn't done before this committee commenced. This was done after the committee commenced. It's not an issue, Steve. Read your own narrative. You're talking about the committee. The committee itself is this meeting, the whole agenda.
Mr. Chairman?
I think when you read that back, I think it is specific that before you go in to debate on a particular subject, didn't you say, on a particular topic? And that topic being the presentations? Not the entire agenda?
It does not state that. It states the only way for debate to be closed or limited in the committee is for the assembly to specify such conditions before going into the committee of the whole. If the committee develops a desire to have debate limited, it can only do so by rising and requesting the assembly to impose the desired time limit.
Mr. Chairman?
Yes. Go ahead.
If I suggested, what we've just done is wasted a great deal of time trying to save time. If I could just suggest that we move forward with the meeting, you as the chairman have the right to intervene if the conversation gets away from topic. You certainly have the right to stop somebody at that point. Let's move forward, please.
Call the question.
Questions called.
More questions on the floor?
Question on that. The question on the floor is whether or not we are going to do what the committee chairman suggested.
So let's have a vote. All
What are
those
we
in-
voting on?
We're voting on me cutting you off after the time that I think is appropriate, if it's more than 2 or 3 questions. And that we're also, is that how you feel? Would that be accurate in terms of how you guys feel about what we're now trying to do?
Yeah.
Okay,
No.
my suggestion is this, let's go this way. I will allow as many questions as I think that I think are necessary to get your points across, but as Tony just suggested, after like the 3rd question or the 4th question on each presentation, I may use my own judgment and say that that's enough, because you agree to that, and does Mr. Burke agree to that?
Well, here's the problem with it, Bill, is that I've researched this to great extent. Is that the case with all of our legislators? Have they done the same amount of research so that I have questions that I think are relevant to the decision in front of us? I think they're pertinent questions. And if anybody thinks that they're not pertinent, then by all means share them with me. But I see this as nothing more than trying to shut down people like me who have legitimate questions. And am I happy with that? No, I'm not. And I don't think the rules call for that. And again, if people have the same level of preparation that I do and my colleagues do, then they should have questions. And if they don't, then I guess my conclusion would be that they aren't prepared for this meeting.
Well, my response would be, we're not saying you can't ask questions. We're suggesting that we do something here in the light of trying to get through this meeting tonight and at a reasonable time. And we figured that 3 questions apiece for each presentation pretty well cover any questions that would be needed in this situation. But
well,
go ahead.
Bill, I guess my question is who is we? Who is we that feel that 3 questions is sufficient?
This legislature, that's why I asked you to vote on it all. Everything that I've just suggested here, I asked for a vote on, and so that's who we are. Go ahead, Mr. Denise.
The amount of time that we've spent on this, Mr. Burke had asked 3 questions, and Ms. Haggard wanted to yield her 3 questions, and somebody else wanted to yield their 3 questions, we could have been done and moved on.
I agree.
So, are we back to where we're going to vote on the question, or is it a moot point?
Move forward.
What would the county attorney suggest?
This has become an issue really of politics, not of form.
Yes.
So this is not a question for me to answer. I can tell you that there are ways in which to pose a motion to limit debate with respect to time, with respect to the number of times, in fact, that an individual is permitted to speak. But I haven't heard a question presented to the floor, and it's not really my prerogative to tell the board one way or the other which way they wish to go on this issue.
Mr. Perkins.
Thank you, Mr. Chairman. Let's just move ahead to the presentations and get it done.
Is that, show of hands of the people say we just should go ahead with this, and we'll go from there. We got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Looks like there's 10 at least. So let's just go ahead with it then. All right. We have a presentation that is coming from Jamie Smith, Behavioral Health Services Line Director of St. Lawrence County Health Systems. And are you there, Jamie?
I am. Can you hear me?
Yes, we hear you loud and clear.
Excellent.
And
So-
go ahead with the presentation. Sorry
There
we took
is-
so long.
No,
Go
no
ahead.
problem at all. There is a there is a PowerPoint that I sent off earlier today. I don't know.
She can control the two.
She has the option, Bill, if she wants to pull it up, or we can.
One more time.
If she would like to control the screen, she can provide her own presentation, or we can pull it up.
Can she hear that? You can provide your own presentation or we can pull it up.
Yeah, share the screen. If you want to share the
Okay.
screen.
This might take me one quick moment to figure out. Do you know how to share this? I'm not sure.
Well, Bill,
Would I do
Mr.
this?
Chair, why don't,
Yes, Mr. Ray.
we have the capabilities, Ms. Smith, we can bring it up and then you can just tell us to move one
through.
slide
Okay.
at a time.
That would be
Okay.
great. Thank you. I would appreciate that.
Okay, let's do that.
Okay, let's go with that.
All right, St. Lawrence Health.
Hello, so my name is Jamie Smith. I am a licensed psychologist and I am the Behavioral Health Service Line Director for the St. Lawrence Health System. And I just wanted to start tonight by saying that we feel honored to be with our community partners, St. Joe's and the county services. I think that each of these organizations do such an amazing job trying to reach our patients in the community and help us to manage this huge substance use disorder problem that we have. And so we feel pretty grateful to be here with you, St. Joe's and the county, as we're working to try to see how we can set up this OTP project. So what I'd like to do is spend a moment talking about the St. Lawrence Health System so you can get a sense of who we are and why we think that we are uniquely positioned to provide this service to our community. So on that first slide, I don't know, I can't see what you're seeing, but on the first slide is
Yeah, that's.
We gotta pick which one's hers, that one? There you go. There it goes.
All right.
That's right.
All right.
Okay.
All right, next slide.
Great, we can go right to the next slide. Thank you. So we are at the health system, we are improving health and expanding access to healthcare. We were established in December of 2013. We are a collection of 3 hospitals, Canton, Potsdam, Governor, and Messina, and that includes both inpatient and outpatient care. We work together to increase coordination and integration of services. The health system is also the largest employer in the county. We have over 2,000 employees and approximately 200 full-time medical staff members. Next slide. At the health system, we really are dedicated to providing excellent care. We believe in evidence-based practice. We are patient-centered in our treatment. We always work to be trauma-informed. Being culturally competent is very important to us. We work to be linguistically acceptable, and we are gender affirming. We really believe that care is all-inclusive, non-discriminatory, and should be tailored to meet our patients wherever they are, regardless of their ability to pay. I wanted to spend a minute to talk about our leadership team. At the St. Lawrence Health System, we really believe in providing cutting-edge behavioral health services, and I believe that that comes from our leadership team. We are comprised of practitioners, and we really prioritize research-driven approaches. I'm so proud of this team. We work so hard to help motivate and grow our staff so we can give the best services possible to our community. So we have 2 medical directors, both of them are psychiatrists. One is Dr. Joseph Solo. He is our outpatient substance use disorder services medical director. And then we have Dr. Azar, and she is the medical director for our inpatient substance use disorder services. And then we've got directors under that who keep an eye on everyday operations. And this includes not only inpatient and outpatient substance use disorder services, but outpatient psychiatric care. We very much view substance use disorder and psychiatric disorders as being sort of in the same vein. And so it's very important for us that we are working together from all angles to serve our patients as effectively as possible. This leadership team meets every week to discuss our services. This leadership team oversees services throughout each of our hospitals, inpatient and out. So it's important for us to have that consistent care, regardless of where you're going to get your service. You can be assured that that service is the best possible. Next slide, please. SUD care is something we've been doing for more than 35 years. I'd like to tell you about the services that we have. We have a detox service at Gouverneur Hospital. This year, we've served already 364 people. In this service, we work to safely withdraw people from drugs and alcohol, and we do this utilizing a multidisciplinary team. We also have an OASIS certified inpatient rehabilitation center. This is here in Potsdam. We have 17 beds. We work so hard to provide trauma-informed care, use many different modalities, and we are a medically supervised inpatient service. We have an OASIS certified intensive outpatient in Potsdam. Intensive outpatients is a great service because some patients, you know, the traditional once a week meeting with your counselor outpatient, it's just not enough to help them in the road to recovery. Intensive outpatient can come in here. We offer 3 days a week, several hours a day of group and individual therapy. So the person can still receive their treatment and not have to go inpatient. We're always striving to have the least restrictive care. We want people to be home and being able to get their treatment and be safe. So that's the great thing about intensive outpatient. We also have 2 outpatient substance use disorder clinics. One is in Gouverneur, one is here in Potsdam. And at these clinics, we provide all of the traditional services, MAT, group, individual assessments. We treat patients' families. And so these centers are very important. The most exciting program that we've just brought online within the past year and a half is our MRAP program. And this spans not only through our hospital system, but to any system in our county. The staff in this program will meet with women who are pregnant or who have just delivered, and they will literally wrap services around these mothers. They will coordinate with their OBs, make sure they get to their appointments, make sure the MAT provider is on board. And we have, thanks to this team, we have been able to supply diapers, playpens, clothes, food. We have had several babies that were born healthy because the patients were able to feel trust in someone and help them navigate through the system. So that's been a really exciting project for us. Slide. So if you don't hear anything else or remember anything else that I'm saying today, I hope you just please remember this. We are one system and we have the ability to do warm handoffs. We can have continuity of care and we can quickly and responsibly move our patients to different levels of care. We know that SUD treatment and recovery is not stepwise. It does not follow a certain progression. There have been times where we've had patients in our outpatient clinic and we've quickly realized this patient needs detox, and our staff have literally walked them to the detox service, done that, I don't know, I guess we could call it a hot handoff at that point, face to face, making sure that they have all the information that they need. We have people who are on rehab who might need to go to detox or from detox to outpatient. We have the same leadership, the same staff. We really meet those patients where they are. But there is one service that we're missing. There is a level of care that we don't have, and that level of care is the opioid treatment program. This program will save lives. This is for the people who have not been successful inpatient. They struggle to be successful outpatient on MAT. It's just so necessary for our county to save lives. And I feel that St. Lawrence Health System, we really are uniquely positioned to fit this service perfectly into the services that we provide for St. Lawrence County. Next slide. So a lot of the presentations that you're going to see today, when we get into the nitty gritty of what an OTP needs to have, it's going to be the same. This is a very heavily federally and state regulated program. So I know we only have about 10 minutes to talk, and I'm going to try and fly through this part, but I want to show you the things that we want to do that might be different from what our friends are looking to do through the county or through St. Joe's. We're interested in having this OTP at the St. Lawrence Center in Messina, and we think this is a great place to put the OTP. We want to do it adjacent from where the United States Department of Veterans Affairs outpatient clinic is, and we're going to set up our program to be very similar in the way that they have their confidentiality protections. We will have an exterior entrance, solid walls on the interior facing the clinic. We're going to ensure that we use the extensive internal controls. And also for our clinic, we're going to use our signage that it will be discreet, but it will consist of the branding that you see in the lower right-hand corner of your screen. This is the branding that SLHS uses. The community will recognize that and trust that. And I think, you know, there's also nothing wrong with bringing people to the St. Lawrence Center as well to kind of help boost the economy there. So I think it's a win-win for everyone. Next slide. When we're talking about OTPs, it's so important to make sure that we have the safety and security. These are some pretty serious drugs that we would have available at these sites. We want to make sure that when we're creating this space, we do so with a physical environment that meets all the requirements from the DEA, federal, state regulations. We were working with Barclays in Canton. They had all of the DEA regulations, and they were able to find a safe that we think is just fantastic, that will keep the medication safe. With a safe room, we have badge readers and cameras and security guards. So these are things that we already have throughout our system. We have established relationships with Genetech. That's the company that provides these services. So we feel that we're already in a good position to just expand these services in the clinic. Next slide. We will only dispense an oral form of methadone. Originally, we were planning to use tablets. Since then, we've had the opportunity to talk to several OTP providers across the state, and we have found that the most effective way to deliver the methadone would be through a liquid and a pump. We're also going to utilize a Cactus Smart Sync system to ensure that medication is not redistributed or diverted in any way. We'll have daily audits, and we'll be sure to follow all of the regulations put forth by the law. Whenever medications are taken home, we'll make sure that those are clearly labeled, and we'll really vet our patients to ensure that they are safe to transport that medication and keep it at home in a safe way. Next slide. Our dosing schedule, our clinic will be open 6 days a week, and the dosing schedule will be from 5:30 a.m. until 10:30 a.m. It'll be very important for us to assign appointments to our patients and stagger them throughout the morning. We will not have lines. We want people to be able to come in, get their medications, and go to work or do wherever they need to do that day. So the importance will be to really keep that flow going through. We will do take-home medications with patients as it's appropriate, and we will conceptualize this as a progression in treatment. Next slide. This just kind of gives you an idea of the staffing. Again, this is similar to, you know, what the other plans will look like. This is what Oasis is asking for us to have. Next slide. For the way that we're going to make this sustainable for us is we are going to reconfigure our Potsdam SUD clinic. We're going to take a couple of our providers from that clinic to staff the OTP. We may also share the clinic director with other established service lines, much like we do now, to ensure that there's continuity across services. Once our clinic is established, we are hopeful to get a waiver to allow the mid-level practitioner to complete those initial examinations. And our friends in the field have told us that this is a great idea. It helps to increase access, but of course we won't do this until we feel like we've got a good foothold with what we're doing. We will hire a medical director for that role, and I will serve as the program sponsor. Next slide. This is, it talks about our training. For us, training is so important. We really want our staff to be ready to meet this challenge and to provide excellent care for our patients in whatever part of their recovery they're in. They need to have extensive training on stigma, to operate in recovery-oriented systems of care. They need to know our diversion plan. All of our staff are trained in trauma-informed care. So what that means is as soon as a patient calls the clinic to make an appointment, we are already treating them with the possibility that they may have endured some significant trauma, and we need to honor and respect them and respect where they are in this process. So every point of service will have trauma-informed care. We engage in crisis prevention intervention. All of our behavioral health staff are trained in this, and that's to help us be able to manage any behavioral emotional issues in an effective way. And we always have various cultural competence trainings frequently throughout our service line, and we will continue with that. Next slide, please. Admission and discharge is a huge issue. We really want to make sure that our patients have ease of access. That is so important. We want to have same day, next day service. We want to be able to complete all the necessary screenings and labs to allow for these patients to receive the life-saving medication they desperately need as quickly as possible. Special care will be taken to ensure that pregnant women, those with chronic immune deficiencies, and those who are taking drugs intravenously get that rapid access to care. We're always going to make sure that our patients are full consent and that they've had an in-person physical, that they really know what's going to be happening, what that medication will look like for them. We will never engage in dosage capping. We will not engage in standing orders. We will never use dosages as a system of rewards or punishments. We will look to prescribe in a way that helps with withdrawal and cravings, and that's all. And the research is really clear about that's the standard of care. So we will ensure that we employ that standard of care in our practice. Next slide. Patients will never be denied admission based on prior treatment history or toxicology results. If a patient, it's determined that that patient needs a different level of care, that patient will be promptly scheduled with an appointment. There will be a warm handoff. We will get that patient to the level of care that they need as quickly as possible. We don't talk about discharges anymore. So this is kind of a move in the field. We talk about level of care transitioning and continued care, and we're going to make sure that that's the language we use in our OTP. In addition, there is the issue of administrative discharge. We are hopeful that we will never have to engage in administrative discharge from our program. Should we have to do that, it would be a medically supervised withdrawal. Next slide. In terms of treatment, you know, I think there's so much to say, and we only have a couple minutes to say it, but I just really want you to know that we firmly believe that our patients need to have choice. They need to feel empowered, that this is their treatment plan, that we are there to support them in their road to recovery, but they're going to paint that picture. We're just going to help them get there. We're going to use cognitive behavioral therapy, solution-based approaches, dialectical behavioral therapy, family therapy, MET. We're going to be in it with them for the long haul, and we're really excited. We're hopeful that this is something that we'll be able to pursue, because we think that we'll do an outstanding job helping the people of our community. So on the next slide, we do have our budget. As you can see, these are our staffing expenses. And then the slide after that is where things are a little bit more interesting, I suppose. This is the operating expenses. So if you'll notice in the year one, we included the startup costs in with that year one, and there's a pretty significant loss first year. And we know that's going to happen. But at second year, once we are able to bring more patients into the practice, we have the ability to make some revenue, which was pretty positive. But you know, OTPs, it's a difficult business. It's pretty significant upfront costs. But I think it's worth it, and I think the people of our county deserve this service. And so I think it's something that we should really undergo. So I feel like I really kind of flew through everything, and I'm sure I'm leaving some things out, but I wanted to make sure that I kept as close to the time limit as possible. And so I understand there may be 2 or more questions, so from each, so we're ready, whatever we can answer.
Thank you, Jamie. Do you have any questions?
Thank you.
Mr. Burke, go ahead.
Unmute.
You're muted, John.
Thank you. Thank you for the presentation. It was enlightening. I have a series of questions, and I'm going to ask them all at once for fear I'll get cut off. The number one question is, would you still be opening the OTP program without the $245,000 allotment or any other startup funds? The location at the St. Lawrence Center Mall, how does that, and your hours of operation are 5:30 to 10:30 a.m. Access to care is important, and I'm just wondering about the transportation route. Is it available out there during those early hours? And your readiness for implementation, have you secured, or where are you with your plans? Should you be given this for the actual implementation? How close would you be? And I know you mentioned the 2 LPNs would be providing much of your medical services. OASIS doesn't allow billing for LPNs, and I guess I would wonder how you might comment to that. And the clinic director you indicated in your presentation might be shared with other service lines, you know. And I guess initially, looking at your presentation, it at least for me, maybe I didn't understand it, it gave the impression that there would be a medical director at the salary of I believe it was $300,000 that appeared to be exclusive for the OTP service, and I know that was highlighted as a strength in the review of your proposal, but you're saying that clinic director may well be shared with other service lines, so they would be doing other work other than the opioid treatment program. I guess if you've been able to capture that, access, security, readiness for implementation, and what you would need if you were given the nod, the go-ahead on this as far as funding, if you wouldn't mind commenting on that.
Excellent, thank you. Yes, I was frantically taking notes, so I do think that I have most of the questions. I think my understanding is that the 245,000 is no longer available, and so that those are discussions that we've had with our team and our administrative team here. I think the St. Lawrence Health System recognizes the need for this service, and I think if there will be funding, that's something that we're going to be very interested in. As you can see, we're going to take very heavy losses the first year, and I'm sure everyone knows that hospitals are not faring well these days with COVID. It's been rough. So I think that we are very hopeful that there will be some funding. But I think that that's something that our administrative team is going to continue to have discussions on, should we be given the approval to have this project. So the mall, we thought that this would be a good location. It's our understanding that there is volunteer transportation as well as a bus route, a public transit at 5:15 a.m. it starts. So people could take the bus there. There is that external door too, so they could come through that door. It's not like you have to wait for the mall to be open to come. But the goal of really setting those hours so early is so that people can have functional lives. We really want them to be able to get in, to get their medicine, and then be out in time to report to work or to be able to get the kids to school. So it's really important for us to have those early morning hours, excuse me. Access to care is huge. And we work with all of our patients to ensure that they have the transportation to get where they need to be. In terms of where we are with the plans, initially we were under the impression that we were going to have the project. So we did start doing some things. We did meet with the folks at Messina Mall. We were able to locate the place where we were going to set up the clinic. It's actually where the bouncy houses are, and I had extensive discussions with the people there to ensure that that bouncy house place would be moved somewhere else in the mall, or otherwise my children would disown me. And I was assured that that would not be the case. The bouncy house place will stay, but that was the place that has that external door. I'm not sure if people are familiar with that area. And so it's a huge, lovely space. And we'd really be able to build per DEA. It's just an open canvas for us to be able to do that. So we started in that process. We started working with Barclays to get that safe. We had the conversations with Genentech. We also were able to make a pretty strong connection with an EMR, Methasoft. We were working with them and kind of finalizing what that plan would look like to implement that EMR and that liquid pump. And then, everything, and then it ended up not being the case. And so we just sort of put things on pause, obviously. But I think that we are ready to go as quickly as we can. In terms of the LPNs, they can work under the supervisions of RNs. And we are going to have that part-time nurse practitioner. And so as long as we have those supervising people there, the LPNs, what they do does count. In terms of the clinical director and the medical director, just to clarify, so those are actually two different roles. The medical director is a physician, and we want a psychiatrist, and he will be dedicated, he or she will be in that role, and that will be their primary function. When I talk about the clinical director, so right now, with that slide, when we talk about leadership, all of our outpatient SUD is overseen by one director, and then all of our inpatient is overseen by one director, and then our outpatient psych is one director. So we do that very purposefully for continuity. I think originally we were thinking, can the clinical director function in that way, continue to be a service line leader? I think we're going to continue, that might be an evolving conversation. I think, again, with this project on the front end, there's a lot going on, the DEA regulations, federal regulations, state. We're probably going to need someone full-time to be managing that. And then once we get the hang of it, I anticipate that person will be able to step back a little. But those things are fluid. I think I got them all, I hope. Oh, I'm sorry, you're muted.
Go ahead, Mr. Burke.
I don't know whether I mentioned it or not, but the along with the access to care, you made it clear in your presentation that you wouldn't deprive anybody based upon prior performance or prior enrollment issues. Is there anything else that would they be denied services if they didn't have insurance, or would you have to have insurance before doing the assessment?
No, absolutely not. This is life or death. Our patients, if they don't get the care that they need, they could very easily die. And we're not wasting time. We have navigators and all throughout our system that help people get the insurance in a quick way. We have the ability for sliding scale. We have the ability to forgive payments. We've got all kinds of different routes that we can take. No, we will never ever deny care for that reason. Absolutely not.
Thank you.
Sure.
Ms. Terminelli.
Thank you, Mr. Chairman. Thank you very much for your presentation. It's been very informative. I just have a question about the referral process. So it sounds like this service would be provided if some of the other services that you had tried out didn't work for patients. So I'm assuming that means that they're already part of or they're receiving services currently from St. Lawrence Health Systems. So how does that work if you have an outside person? Do they need referral? Do they have to be placed in a protocol of treatment through St. Lawrence Health Systems before they can receive services from you in this capacity for this clinic? How do you see that looking?
They need to call. So they need to call, whether it be that person individually or maybe their therapist from another SUD clinic or from a rehab downstate or whoever they're hooked in with, or just self-referrals. We get self-referrals all the time for our detox services and our inpatient services. Our primaries refer. A lot of times your primary care doc can refer inside, outside of the organization. So we'll want to ensure that all the organizations throughout our county and beyond have the ability to refer with ease so that we can get these folks the treatment they need in a very timely fashion.
Mr. Lightfoot.
Thank you, Joe, for the presentation. What criterion did you use or are you using to make the decision that if in fact you do operate such a clinic, that it should be held in Messina? What entered into that, and specifically at the mall in Messina? Is there some other connection between your organization and the mall, or I'm looking for your rationale and your reasoning?
Sure. Yeah, no, that's a great question. Thank you. Space is the trick. The mall right now has a lot of space, open space, and they've been very enthusiastic to have people use that space. At a fairly decent price. They have worked with us when we've talked about what construction could look like. How can we pay for construction? Can we have these hours here very early? I think unfortunately there's a little bit of a stigma for OTP services, and a lot of people will sort of say, I don't want an OTP, in my neighborhood or in this area or in that area. We had not found that at all. With our with Messina Mouth, they've been really excited about bringing that service line in. We were also thinking it's right across from the VA clinic. And so I thought that's kind of a nice touch. People can get their healthcare there. They can get their healthcare here. Also, I understand that this is kind of a wave of the future, that there's lots of these sort of outdated I'm not suggesting they're outdated. These sort of like shopping malls, right, that aren't being used anymore because people are doing so much online buying, that the newest sort of thing is to take these spaces and use them for medical offices and for medical space. The fellow that we were talking to, the architect who was starting to lay out the plan, said that down south this was kind of a new thing to do, because there's so much room, there's so much space. It's already kind of a commercial area. And we also thought it was a nice touch to bring more business to that area. I think that's positive. We can kind of get a 2-for-1 on that. But no, there's no other ties between our organization and theirs.
If I may follow up.
Follow up, Mr. Lightfoot.
What happens if once you are in business and you find that
most of your clientele is not from the northern part of the county, and that you are actually doing them a disservice by putting them in a car or a bus or whatever mode of transportation they would need to get to Messina, and then, the same ride back home. Somebody from Hammond, New York, it's a day trip to go up, get your medication, and everything that goes along with it, and then go back. It seems like a rather large inconvenience. Is this something that you would reconsider, the locale where this would be conducted if something like that occurred?
Sure, yeah, I think, what we want to do is provide a service that is the best service we can provide for our community members. And so in that vein, we are open to having those discussions. I would just say right now, our patients in our county are traveling at least 120 miles one way. To get their medication. So there is a clinic, I believe, in Plattsburgh, and there's one in Watertown. And so the southern part of our county is already probably being served by the folks in Watertown. So we, kind of being in more of the northern section, we can provide services to those folks up there. But it's not something that we're married to. Again, I think we were really excited about being able to have this fresh space, large space that we could use to design from the ground up safely. And though that was kind of the thinking behind that, but of course we'd be open to that.
Thank you very much.
Thank you.
Legislator Kern.
My microphone doesn't work, so let me know if I need to speak up. One of the things that I liked about the idea of the Messina location is it's similar to the VA. There's a VA CBOC in Watertown, there's a VA CBOC in Plattsburgh, and it's sort of equidistant, from Messina to Plattsburgh, from Messina to Watertown, and I think that's why the VA set it up that way. We were sort of happy at the idea of having it at the mall simply because we have a number of veterans that would be able to go there instead of Watertown or Syracuse. My question is, do you know how many, what length of time it would be from the time you get the go-ahead before you feel you would be up and running?
Yeah, thank you. I think that that will be dependent on whether or not there's any funding available. I'm not sure what that would look like. Obviously, our goal is to move this along as quickly as possible because we understand that lives are at stake. But yeah, those would be discussions that we could have once we have a better sense of whether or not there would be funding available.
I know that you've been working, am I allowed to do that though? I know that you've been working on this since last year when they did the preliminary scouting there. Do you guys have all your plans and everything drawn? You really are all ready to pull the trigger, right? As far as preparation?
Yeah, for the most part, I think, there have been a couple of last minute, going back to the drawing board to make sure that we were conceptualizing this correctly. Again, this isn't a service that we've done before, but we've had an excellent opportunity to be able to create partnerships with other OTPs throughout New York State. And to join some of the groups, COMPA, there are some groups out there at advocates that really took the time to sit with us and say, have you thought about this? Have you thought about that? And I think now we are at that place where we are ready to go.
Thank you.
Any further questions? Go ahead, Nicole.
Thank you. It's just for clarification to follow up on Rita's question. I'm not quite sure if I heard a time frame. Can you give us a best case and a worst case scenario with the actual possibility of time on there? I may have missed it. You said.
I think worst case would be a year. I think 6 months would be best case. And again, this isn't so much driven by us. So the DEA will have to say, yep, you're good to go. SAMHSA will have to say, yep, you're good to go. OASIS. So there's just levels. It's so heavily regulated. So I don't want to say too much and then not be able to deliver, not based on us, but based on, the federal regulations and everyone that needs to give their say so.
Mr. Burke?
Margaret,
We-
got her hand
Mrs.
up.
Haggert's had her hand
Margaret, I see her.
quite a
I'll get her
while.
next. Margaret, why don't you go ahead, because we can't hear Mr. Burke.
Well, I think John, are you ready?
Go ahead, Margaret.
Thank you very much. Okay, thank you. I have 4 quick questions. Thank you very much for your presentation. In the beginning of your presentation, you said that you were going with liquid medication that was administered with a pump. And then you referred to take-home medication. Do they take home liquid medication with a pump?
I'll unmute myself. Just to clarify, so the pump is actually what is used to dispense the medication. So the pump is like connected to the EMR, and then the pump dispenses the perfect amount of medication. It takes out that room for human error. So then what will go home is what is dispensed, not with the pump.
Okay. Did you say the only detox was in Governor?
Detox services in our county are located at Governor Hospital. It's not an OASIS certified detox, but it is a detox service. And we've got about 8 beds there that we utilize for that.
Okay. You also referred to a volunteer ride system. I know we're having trouble getting Meals on Wheels out to people because of lack of volunteers. What is the network that you use for volunteers to get to people to Messina?
Yeah, it's the Access, it's the Access program that's through the volunteer transportation for the medical appointments. Is that, am I correct? I'm just checking. Access, yeah, transport.
I didn't catch the end of that.
It's MAS, the Medical Access Service, I believe is the acronym. I hope I'm not fibbing
Okay.
that, but yes, MAS.
Last thing, we all want to know whether we're doing a good job or not. How do you evaluate the quality of your services? Is it just through patient feedback? What is the procedure for that?
Yeah, so we've got so many mechanisms for that on a very large scale. OASIS is always we just had a recertification for one of our outpatient services. So we've got these larger organizations like OASIS that check in on what we do. We would look to be CARF accredited if we do get this service. CARF accreditation they would come in and check to ensure that we're doing the right thing. Patient feedback obviously is very important. Family feedback is very important. We do monthly compliance reviews, monthly incident debriefings, monthly. I had a slide about our quality controls, but I cut it out just as I thought we would run over. But yeah, through our whole hospital system, there is a large compliance and what is the word that I'm looking for? Quality council. So I sit on those boards for the hospital to share the information, but then within our service, behavioral health service line, we have our own where we just focus solely on behavioral health across all of our behavioral health services. So we've got the big level, the big organizations, our hospital, and then we've got our service line. There's lots of oversight.
Okay, one more quick thing. I'm sorry. I want to be sure that I understand clearly, and I think Mr. Burke asked this, but I'm going to ask it again.
Sure.
That no matter whether I can pay for services or not, I will be served by your clinic. Is
You
that
absolutely
true?
will. Absolutely. Yeah. Mark my words. Yep. Yep. You
Okay.
will. Yeah. Mm-hmm.
Thank you very much.
Sure thing.
Mr. Burke?
Do you have a floor plan for your proposed service? The reason I ask this, it all relates to the readiness for implementation. I think at least many of us are concerned about how quick this could get off the ground, and you know, just wanted to ascertain whether or not you have a floor plan and a design ready to go. I know that I believe that some of your construction, like in Governor, may have been halted due to the COVID. So just wanted to get a sense of how quickly this could happen and how ready are you with contractors and floor plan should you get the go-ahead?
Yeah, thank you. No, that's a great question. You're right. Our governor first floor program, because of COVID, the construction was halted. Thank goodness. They're underway now. They are doing that construction. So we were meeting with the architect. We were doing the walkthroughs. The architect was doing the drawings when we got word that we did not actually receive the program. At that time, things kind of halted because we didn't know what was going to happen with that. What I have told my staff and the IT team working with the Methosoft ER and facilities that are working with the architect is, hold tight. We're going to put this on pause, but I want everyone to be ready to go back full cylinder if we are to get the approval. So we have a pretty firm pause right now. I think the enthusiasm there for this project is great, and yeah, we're ready to go full speed ahead should we get the nod.
Well, the reason I asked that is because some other proposals had a floor plan, and the preparation as to what they would do, how they would progress, without knowing whether or not they would be awarded the program or not. Thank you, though.
Yeah, and I think, just to add, and I'm sure that you're all aware of this, but COVID was particularly difficult for our hospital system. We lost so much revenue because of the outlying clinics that were not able to operate. We took a huge hit. And so I think our hospital administration is so dedicated to behavioral health, but at the same point, funds are limited. We have to really be careful how we're spending money. And I think when we were told that we were not going to be receiving the $245,000, when we told that we weren't going to have that project, we had to just to be fiscally responsible, kind of just take a time out. That certainly does not speak to our enthusiasm, willingness, motivation, and drive to do this. We do have our outpatient clinic interior designs all sketched out through Sedgwick, and that's something that we can share. So we know what the inside of our clinic is going to look like. We know we have all of our furniture picked out. So we have all those things in place. The thing that we just really needed was the architect's drawing of the floor plans. And again, those are something too that we always wanted to make sure that we had DEA on board with, because we didn't want to pay money to get the sketches drawn for the DEA to come in and say, hey guys, we need you to do something a little bit different. So we're just trying to be as cost effective as we can during this time.
Thank you.
Yeah, thanks.
Next.
No more questions? That sounds like that's about it, Ms. Smith. Thank you very much. It was a very informational, informative presentation you made. Thank you. Made it quite clear.
Thank you. I appreciate your time. Thank you.
Thanks.
Okay, the next person on the presentation list is Bob Ross, who's with St. Joseph's Addiction Treatment and Recovery Centers. He is the president and CEO. Bob, are you on?
I am. Can you guys hear me?
Yes, good. I can hear you. Go ahead, sir.
Thank you for the opportunity. We prepared a very brief presentation. We're going to try and stay within the 10 to 12 minutes that we were asked to, and then be available for any questions. Thought it would be helpful for you to have exposure not only to myself, but to our medical director, Dr. Biaggi, who is with me, and our Zach Randolph, who is our Chief Clinical Officer. So I'm going to just take 3 or 4 minutes and then pass it on to Dr. Biaggi. Next slide, please. So the reason that this project is so important to St. Joe's is that we are committed to having as expansive a continuum of care as possible. In the last 6 years, we've added a veterans program, we've added an adolescent program, we've added supportive housing projects for our individuals who are in treatment or have left treatment. So the idea of having a continuum of care where people can pass from one level of service to another is essential to us. We very much are committed to a trauma-informed and individualized care plan. We have been in operation in St. Joe's for 49 years and 30+ years in St. Lawrence County. Our commitment is to have all of our integrated services lead to sustained recovery. Briefly, on terms of the budget, you've received our budget. We have not amended that since we presented it initially. We recognize that there are some adjustments in terms of funding. The $245,000 that was available initially is not available any longer, but we understand that there's a potential, not definite, $900,000, and a portion of that, if St. Lawrence County receives that grant, a portion of that would be used for the OTP program. Our assumption is that we would be, if we receive the award, negotiating with the county as to how you would use that $900,000 if in fact you're awarded that. My understanding is that that comes at some time early in October, so the timing of that is pretty easy to understand. You would ask the previous presenter, so I'll offer a quick indication that from our point of view, the expectation is that we would be ready to implement at some point between 6 to 8 months. I think that that's realistic, considering all the work that has to be done. One of the things that we do not have to do is worry about space, because we've already secured the space. We operate an outpatient service in Messina on the grounds of the hospital in an independent building that's on those grounds. We have secured and signed a lease with Messina Hospital for additional space that is sufficient to occupy the OTP, and with very minor renovations, which would not be costly, we would be ready to operate very quickly. We have been working diligently with the Cradle Community Center, with Farnham Family Services, with Crouse Hospital, and with Helio Health, all of whom run OTPs and have given us counseling and support for the design of our program, and also would be available to help us in the implementation. Our understanding is, and we've not run an OTP, but we have run many other types of services, is that it's a very complex system to operate successfully, which is why we have had those 4 individual supports, and we would continue to do that. There were some letters of support that we shared as part of our presentation, but not part of the PowerPoint. We also have worked very closely with citizen advocates who have provided an indication of their support. They would be potentially sharing some staff with us. They also operate in St. Lawrence County, and we appreciate the opportunity to continue to work closely with them. The last point I will make is that in terms of our credentials and qualifications, we are CAR certified in all of our activities. That is a 3-year maximum award of confidence, which we have maintained. St. Joe's has on 8 separate occasions been identified as the best company to work for in New York State. And I would conclude by saying that we have been superbly diligent with the assistance of Dr. Biaggi, who I'm going to turn over to in a minute. Dr. Biaggi has allowed us to operate during the COVID period with none of our staff being positive and only 1 resident. And we had meetings frequently. I think we've had over 100 meetings of our COVID committee. And during those meetings, we talk about tweaking all of the details. So we take very seriously the need for safety during COVID. So those are my initial remarks, and I'm going to turn it over to Dr. Biaggi, who is our medical director.
Yeah, good evening. My name is Hector Biaggi. Bob asked me to talk to you about the credentials, and then I thought to myself, gee, I need to explain an alphabet soup of degrees that I have. But the most important thing is that I'm a psychiatrist. I am also a child and adolescent psychiatrist, and I'm also an addiction medicine specialist. I graduated from medical school in 1995. And then after that, I went to Montefiore Medical Center, Albert Einstein College of Medicine for general psychiatry. And then I did my fellowship in child adolescent psychiatry at Columbia Presbyterian Medical Center. After that, I went to Miami, Florida, where I was a medical director of a juvenile addiction receiving facility associated with Jackson Memorial Hospital, the second largest medical center in the nation. Back, a few years ago, I then moved to the Syracuse area. Actually, that was in 2008. And then I began working for Crouse Hospital. Crouse Hospital does have a big OTP clinic. By the time I left there 7 or 8 years later, they had a total of 600 patients. I also was a medical director at Commonwealth Health, which is a 28-day rehabilitation program. During my stay at Crouse Hospital, I was exposed to the big hospital system, and I also was part of a small department that was competing with other major departments such as surgery, neurology, radiology. And it was a unique experience. Now, 4 years ago, I moved to the North Country, and then I became the medical director here at St. Joe's. Right off the bat, I was impressed by the culture here, which is very, very supportive of the patients. I also was impressed by the continuing of care, all the levels that you see in needed care in the addiction field. Hopefully, if we get the grant, of course, I will be overseeing the OTP program, and in reviewing the RFP and also the other documents provided by St. Lawrence County, I found it interesting that you guys are interested in stigma reduction. Our board here in St. Joe's, the main points of agreement with you guys, and I think we could work with the county to do some outreach in the Messina area if you guys think it will be appropriate in the future. Zach Randolph, over the last couple of years, spearheaded by OASIS, there was a stigma reduction campaign, and then we made several presentations. I also would like to, add that while we have been here in the last 4 years, we're able to develop a hepatitis C treatment program. Also, we were able to treat people on methadone. By that I mean we reach out to other OTP programs, call them and say, hey, listen, we're willing to accept patients to a residential program if you guys think it will be appropriate. And then, of course, they agree to that. And up to this moment, out of 50 patients that we have because of COVID, inpatient residential program, we have 6 patients on methadone. And that was done only through contact and networking with other physicians. I would like also to add that I am a board member of NICEN, New York Society of Addiction Medicine. I'm part of the membership committee. And then that, at the risk of sounding too overconfident, I do have the network for support in development of an OTP program. Zach?
Do you want to forward this?
Yeah. Do you mind forwarding 2 slides, please? Thank you. My name is Zach Randolph. I am the Chief Clinical Officer for St. Joseph's. And I just want to start by pointing out that, in reading and reviewing St. Lawrence's local service plan, your LSP, not only does the St. Joe's fulfill the LSP in terms of your desire to increase the amount of opioid treatment program in the county, specifically with the OTP, But to Dr. Biaggi's point, you know, we look forward to partnering and working on reducing stigma together. We've been striving to bring more MAT providers into our care network, so our agency, and 2 of those have been for the St. Lawrence County area. We currently operate an outpatient clinic in the Messina area. The other thing that I wanted to just kind of highlight, which is the second talking point, is our RFP is a little bit different than what you heard presented earlier, in the sense that we do have leased space. Like Bob had mentioned, it's in the same building that we currently have our outpatient clinic in, that's operating quite well. And we're providing MAT treatment out there as well with buprenorphine and some naloxone if appropriate. And so having secured space already, which gives its own discrete entrance and lobby and waiting area, is a big plus, because it's in the same space and we wouldn't need any extra or additional signage, so it would stay discreet, it would stay local. One of the benefits to that, and part of our plan, is really that we're going to share staff and scale to the volume of services that we're offering. So dependent on how many patients we receive, we will be able to devote time from current staff at the OT or at the outpatient clinic, and like Bob said, in sharing with citizen advocates as well, do some staff sharing, so that as we kind of ramp up and as the volume of services or patients are served, we will then start devoting full-time staff to that. And again, the staffing pattern was in the RFP that we had sent. I think it's a nimble way of doing business. I think it's going to keep salaries down. It's going to allow for us to be able to provide care for those that need, but not necessarily having staff that aren't going to be efficiently used. So I think it's a flexible approach. I think it's a wise approach. We would be sharing, same thing with like direct oversight. Dr. Biaggi is our medical director. He oversees all of our programs. It would just be one more program that creates the continuum of care that we're trying to do. One of the other benefits of sharing space with the outpatient clinic is that recently St. Joe's was the recipient of a major federal grant, which was the Certified Community Behavioral Health Clinic, or CCBHC grant. That allows us to provide enhanced services in addition to substance use disorder treatment. So CCBHC services allows us to enrich the current services we provide by adding mental health treatment, by working closely with primary care providers, by adding care managers, and largely adding peer support services as well. So we, in OASIS, they're called Certified Recovery Peer Advocates, or CERPAs, and those enriched services are going to be happening at the outpatient clinic anyway, so it will make for a nice way for us to tether people who are coming in and starting the methadone treatment to be added and to get included into that care. So it will be nice to be able to have those and be able to provide that if and when they're ready to start engaging in additional treatment. We would start focusing on, you know, some MAT specific groups and individual sessions. You know, a lot of the same modalities and therapy styles that were talked about earlier, to include an additional motivational interviewing so that it's really paced to the individual's needs. And one of the benefits that St. Joe's has is, I think it was about 2 years ago now, we received a grant to open what's called an open access center, and we've hubbed our certified peers out of that. And what's nice about that is that we're able to use them as part of the outpatient continuum of care, so that not only can those peers engage people early in recovery before they even maybe want treatment, they can engage and try and tether them and just stay connected, but they can also provide transportation. So not only can we try and coordinate transportation to and from services, but we're doing that with peers. so that there's a therapeutic benefit to more than just putting the miles in between and getting from point A to point B. There's some work that can be done in creating relationships and keeping people tethered to potential opportunity to start their recovery. Along with the CCBHC services, St. Joe's continues to grow, and I think it's relevant in the conversation that OTP would be adding to that continuum of care. We have a detox program that will be an OASIS certified detox program scheduled to be opening in the Saranac Lake area. I believe that's going to be Q3, Q4 2021. We currently have a relationship that we just started working on with North Country Freedom Homes to help assist them. And we have recently opened, I think, over 40 beds of permanent supportive housing. And then in addition to our inpatient, our adolescent program at Rose Hill, outpatient clinics, our veteran-specific program. So we just continue, what we're trying to do is create that continuum of care so that we can provide not just the entryway to recovery, but that we can really help sustain and support families and individuals walk their recovery out. So unless Bob has anything else?
No, we appreciate the opportunity to have you meet some of our key folks who are going to be involved in this program, and more than happy to answer any questions that you may have.
Any questions?
John?
Mr. Burke has.
Mr. Forsyth?
I'll ask mine. You currently have a chemical dependency clinic in Messina, correct?
Correct.
Do you have a target number per clinician, how many visits they would see in a given day, 8-hour day?
Yeah, in fact, we've actually been working on that over the last couple of weeks to get prepared for our 2021 budget submission to OASIS, and I'm going to ask Zach to respond to that.
Okay, thank you.
Sure. What we're finding is per FTE in terms of billable services, because unfortunately, to Mr. Burke's point earlier, sometimes the services we render that we feel are necessary to provide quality treatment aren't necessarily billable. So that does take away some staff time in terms of creating revenue, but we feel it's appropriate to do so for the care of the person. But in terms of billable services, what we found is that if we can keep our rate at an average of 25 billable services per week per FTE or per clinician, that's a healthy balance between providing quality care and creating revenue that keeps us fiscally solvent.
Okay, so basically 5 per day per clinician?
Yeah, and again, you know, that's 5 billable services. So there's a lot of our care that unfortunately we're not able to bill for, but that hasn't ever stopped us from providing those additional services.
Okay, thank you.
Mr. Burke, did you have a question?
Yes. Thank you for the presentation. It certainly is informative. Would you be able to proceed with the OTP if there is not grant money available?
So I would like to be as direct in answering that question as you want to hear the answer. Our expectation was that there was $245,000. We understand how that has changed, and that's certainly an understandable change, and that there's a potential for $900,000, some of which could be used for the OTP program. One of the things that we did in anticipation of wanting to be as economical as possible is secure space that basically will not require any significant amount of renovation, either money for the design work by architects or the construction work. I think we would have to move 2 walls and a door in order to meet the requirements. So my point, wanting to be as direct as possible, is if the county does not get the $900,000, and if the assumption is that St. Joe's or any other applicant is prepared in the middle of state cutbacks and in the middle of the COVID reduction in revenue to a priori say that under any circumstances, we would be able to sustain funding without any assistance, the answer to that is no. On the other hand, we sincerely hope that the county is in a position where it does receive the $900,000 grant. And if so, we would be delighted, if chosen, to work and create the most cost-efficient program possible. And we've already spent some time and energy and some money on our part to be ready to do that if that opportunity presents.
Follow up, please.
Sure.
Yes, go ahead, Burke.
The OTP, at least it was my understanding, and maybe I'm wrong, but the OTP has to be in a discrete place. You talked about the sharing of services, which certainly, in my mind, on the surface, makes sense that you would share space, share services to save some of the dollars, but it's my understanding that the OTPs have to be in a completely separate space from other services, and if that's the case, then you would probably have to find alternate arrangements for whatever other services are there now. If I'm correct, and I'm not saying I am, but that was my understanding, and maybe you could comment on that.
Happy to answer. It's an excellent question, Mr. Burke. And the reality is that what is required to be separate is the physical space. And that would be separate entrance, no ability to go from one clinic to the other, from our inpatient or outpatient service to the OTP. What is not restricted is sharing staff. So for example, if we have a counselor who spends some of their time in one service and some of their time in the other service, they would walk out the door and in the other door and be able to do that. So you're correct about the requirements of separation, but that does not in any way inhibit sharing staff.
Okay. Just one more quick follow-up, and probably not related to the OTP, but when you talked about productivity and what you expect from your clinicians, what's a reasonable level of productivity, I guess I'm just wondering, does that include groups? Because units of service can get ramped up fairly quick if you have a group of 8 or 10 people. Again, just a question.
Again, a very valid question. What Zach was talking about is the number of billable services. So the billable services are generated separately for individuals and for group members. So we do not simply have lots and lots of groups in order to try and drive up numbers, and it doesn't work that way in the way they're counted anyway. So I think the sense that we have is that what Zach was really describing is a individual workload. The groups are above and beyond that. And the reason for that is exactly what you just described, is that there's no desire on the part of OASIS to have people run lots and lots of groups and have that count as a increased amount of services. We do groups, we do them well, and they're small enough to make a difference and big enough so that there's some diversity in the groups.
Thank you. Thank you.
Tony, did you have your hand up or are you just touching the screen?
Yes, I was having some technical difficulties. My apologies.
All right. Mr. Lightfoot.
Yeah. Mr. Ross.
Yes.
I noticed that you were on and apparently or obviously listening to the previous presentation. I'd like to ask you is what do you see as being a major difference between yourself and the St. Lawrence Health Alliance with respect to providing this service? You know, why after listening to both of you, would you offer why we should choose St. Joseph's over St. Lawrence Health Alliance?
An interesting question, and I'm happy to answer it. From our point of view, it's not so much that we are better than another applicant. It's what we do well and would attempt to do well here in this particular service. St. Joe's has for 49 years provided addiction services, and as has been mentioned, we've added veteran services for individuals who have addiction and PTSD and traumatic brain injuries. We've added adolescent services. We have an outstanding family program. We do not run a hospital, and I fully understand that there are excellent services that are run in hospitals, but we feel that we can provide services in our continuum of care that are more cost efficient. Hospitals are not the easiest place to keep your costs down, and although I admire the work that that hospital does and other hospitals, I think the answer to your question basically is that we would be focused on the behavioral health services that we provide, and that's what we provide, and we would be able to probably be able to do that over time in a more economical way.
Thanks, sir.
Rita Karn?
Hi, thank you for your presentation. So in the event that these patients needed to go to detox prior to starting the opiate replacement therapy, where would they go? You don't offer that service. They would have to go locally, or you would send them to Syracuse?
Well, in about 8 or 9 months, we will operate our own detox, as Zach said. That will open sometime in 2021. And that'll be a 10-bed service that we operate ourselves. And I should also mention that one of the really strong parts of our program is that we have peers who have mobile vans, and we transport from service to service. So if there was somebody at the OTP clinic or at our outpatient clinic that needed to be sent to a detox, we would be able to provide those services.
Thank you.
Go ahead, Ms. Haggard.
I just wanted to clarify something that Mr. Ross just said. You have your own transportation service in-house? You have vans available?
Yes,
okay.
we do.
Thank you very much.
I should also add that during the period prior to our detox opening, we certainly would be able to use the Canton Potsdam Hospital's detox, as we have used in the past, and we've also used Syracuse, and we've also used Albany, which is why we're establishing our own, because going to Albany or Syracuse is not the ideal way to work.
But you do transport your own patients?
Yes, we do.
Thank you, sir.
Yeah, absolutely.
Ms. Terminelli, go ahead.
Thank you. Planned hours of operation for your clinic would be?
Zach, do you want to respond to that?
There we go. So I don't recall off the top of my head what we put in as far as our RFP for the planned hours of operation. But much like you heard before, one of the conversations and one of the ways that we would be talking about this is looking at timeframes that are appropriate for the individuals that are in need. So somewhere between the time frame of 6 a.m. to 9 p.m. And using staff like we had talked about. We have the outpatient clinic that's operating. It's operating on off hours. So we already have staff that would be available that we can kind of round out the time frame. But the reality would be is that's a starting point. So what we would do is, we'd start there with the time frame, and if we needed to adjust it, we would adjust it as we saw a need. One of the points of a methadone clinic is to not only initiate people into MAT, but also create an MAT route that allows people to have fully functional, lives and jobs and things like that. So taking into consideration not just, local transportation times and routes, but also, people's hours that they're required to work and when are they able to do transitions of shifts and things like that. In terms of the patients we would be serving. So I think, we would start with something and we would see if that met the need. If it did not, the conversation would be very quickly to decide how we expand that or how we transition to different hours to make sure that we make this available to those that are in need. And that does kind of speak to one of the quality assurance measures that I just kind of want to, include, is that we do have our own internal units and our own internal processes. But I think part of what we're starting a conversation tonight is we'd like to work with you and the Community Service Board members to get feedback, so that we can get feedback and community input and understand, are we providing services that are not just that are really good quality, but they're also very practical in nature. So I think we would take that into consideration and look forward to the partnership of the dialogue as well.
Thank you. And may I continue just two more questions, Mr. Sheridan? Thank you. Thank you. Just to keep consistent with the question that we're asking, it seems like everybody, readiness, I know that the facility is pretty much established, but what would your time frame look like as far as being operational?
I think 6 to 8 months would be realistic.
Okay, and insurance, would insurance be required in order to receive services from St. Joseph's?
No.
Thank you.
You're welcome.
Go ahead, Mr. Akers.
So, Mr. Ross, so you did say earlier in your presentation that the function of the clinic itself would be dependent on funding. Was that correct?
Absolutely.
Okay. And then for Dr. Randolph, I guess you're not a doctor, but it's close enough. How many patients do you have on Suboxone now that you would anticipate would be in the opioid clinic?
Yeah, my name is Dr. Biaggi, by the way. First name is Hector. As of now, I'm limited to an inpatient setting. And then I have also in this inpatient setting, I see a veterans patient that come up the hill. So I have between 25 and 30 patients on Suboxone. Now, prior to that, I was working on an outpatient basis at the Saranac Lake Outpatient Clinic, seeing patients from the Tri-Lakes area, and my census over there went up to 70, 75 patients.
Yeah, I'm asking, in your Messina clinic right now, how many patients do you have on Suboxone?
The Messina clinic, Zach maybe is going to be able to help me with that. Right now in the Messina, between 150 to 200 patients.
Okay. And that's the question I had for Mr. Randolph is, how many of those patients do you anticipate would take part in your, if we went with the methadone clinic? Do you have an idea? I mean, a lot of the patients that we're experiencing here in the county, well, a certain percentage are abusing the Suboxone, they're selling it and trading it in for heroin. And do you anticipate that the majority of your patients that are now on Suboxone, that they would go to the methadone clinic?
I don't think I would necessarily say the majority. I think that would be a longer conversation for us to start working with the individuals that we're serving on MAT, specifically that are on buprenorphine, to look at, what's their success, how are they doing, are they able to maintain a quality of life and sustain progress towards their recovery goals. I'm sure that there's going to be a cohort of those individuals that would be appropriate for methadone, but I think that's really going to be a case-by-case conversation, and largely right now, I would suggest that anecdotally, I don't necessarily think it would be the majority.
Yeah, I would like to add in my clinical experience, once you have a stable Suboxone population, I will say that between 5 and 10% of those patients might be candidates going to an OTP methadone type of program.
Okay.
Let me just add one quick piece to what Zach and Hector said. From our perspective, and I think all three of us have emphasized this, St. Joe's philosophy in terms of providing sustained recovery is to have as broad a continuum of care as possible. So one of the problems that you are addressing by looking for the RFP, which we applaud, is so that there not be a situation where the OTP is available in Watertown or Plattsburgh, but not in between. So we were very excited when we found out that you were responding to what was in the local services plan and asking for the RFP. We are honored to be part of the application process. And regardless of who you choose to do it, it will be a great service to the community to have the continuum of care expanded.
Yep, and thank you. I mean, that was our discussion here. We knew that people were going as far as New York City for treatment. And we knew that the distance, particularly a Messina location, would be roughly 110 miles from Plattsburgh and roughly about 110 miles from Watertown. So we knew that that people that were seeking treatment here in St. Lawrence County, they would be going in either direction, and that this would be medically feasible in a better case scenario for those people in St. Lawrence County.
Right.
Thank you.
Mr. Burke, do you have your hand up?
No, I don't have my hand up.
Okay, all right. Any other questions? Thank you very much, Mr. Randolph and Mr. Ross and Dr. Biagi. You gave a well-presented presentation. Thank you.
Thank you for the opportunity.
Thank you.
Next is is Sheena Smith with the Chemical Dependency Clinic Program. She's the director for St. Lawrence County. Sheena, are you on?
Yes, I am. Do I have the ability to share my screen? Okay.
One more
Yes,
time?
she does. Yeah,
Okay.
she does.
Can you see my PowerPoint?
Yes.
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 Great. So I'll try to not be too long. So my name is Sheena Smith, as Mr. Sheridan said, and I'm the program director for the County Chemical Dependency Clinics. Also, our medical director, Dr. Norris, is on the line as well, just in case questions come up for her. We wanted to just take this time to talk to you about what we had proposed for an opiate treatment clinic. So first off, about us, I know you guys probably know quite a bit, but I wanted to share. So we are the oldest and largest outpatient addiction program in the county. He has been in the treatment business for well over 40 years. The pictures show the 4 sites that we have, which are in Canton, Gouverneur, Ogdensburg, Messina. COVID-19, kind of forced us to expand to utilize telepractice services, which made the brick and mortar sites really underutilized. And so that was kind of part of our plan. The location we had selected for this project is our Harrogate Commons building in Messina. The Messina site has not been utilized to capacity, and the location easily and quickly modified to provide an OTP service. The Messina satellite would be transitioned to a fully virtual clinic, which it essentially is right now anyway, with ahead with this project. I'm sorry, I have kind of a raspy voice. Other services that I think it's important to mention, as they're very valuable to the community, is our co-location and forensics. Co-location provides screening, referrals, and toxicology testing for individuals with drug and alcohol related. Our forensic services provides counseling, evaluations, groups, and referrals to inmates at the correctional facility. And both services excel at helping clients get connected with the type of treatment that they need. As we know, accessing appropriate level of care greatly reduces recidivism rates for individuals with substance use disorder. And you can see, we do see a pretty large number of CPS referrals as well as inmates. And our staff is always working diligently to get people referred to the appropriate level of care. Another really important part that kind of sets us aside as community leaders in harm reduction is our opioid overdose prevention program. Community Services offers an opioid overdose prevention program and also provides harm reduction education. We're the original opioid overdose program in the county. And in 2019, we trained over 1,000 community members and provided them with kits. So far, it has been slower because of COVID, but we have trained 430 individuals. Despite the pandemic, we continue to offer online training and in-person training to those in need. We've made it so that we can mail or deliver kits to people that, contact us. And we provide a weekly online training. The demand became so great that we ended up sponsoring Seaway Valley Prevention Council and provided them with to be trainers under us to meet the community need. We also continue to provide training kits to many of the county department, training and kits to many departments, the St. Lawrence County Drug Force, various schools, fire, rescue, and police departments. We have provided technical assistance to some of the area schools to set up their own policies and Narcan programs, like plans. We recently began monitoring where the overdoses are to really have an effective program through the ODMAP application, which I'm sure you've heard Dana talk about. And we've started to provide what we call pop-up trainings in those areas where there's, showing overdoses. Most recently, we provided a pop-up training. I think it was 2 weeks ago. Public housing, one of their public housings, Belmont Courts, in response to the ODMAP data. One of the things that we think is good about our program is that 70% of the overdoses on the ODMAP have identified Narcan being used. That's a good start. That means that people are getting our kits and they're using them. So far this year, there's been 33 overdoses in our county and 5 were fatal. Previous years, we were averaging about 1 overdose a month, so you can see that COVID has had its toll on our economy. And I will tell you that I'm on a committee with Art Shattuck, and he told me that when he goes, drug bust sites, he sees our kit there, and that's the place it needs to be. I wanted to just talk a little bit about our staffing. We have a qualified and compassionate staff. 100% of our team hold New York State credentials in their areas of service, so advocates are, SERPA certified. The counselors are all CASEX. 75% of our counselors have a bachelor's degree or higher, and 1/3 of our staff have a master's level degree or higher. We have an excellent medical director who's on, Dr. Norris. She's very passionate about this work, and she's committed to treating people with use disorder. She's also the medical director for St. Lawrence ATC, which creates a wonderful connection between our 2 programs and has proven to be quite helpful. Has significant experience within the substance use disorder field. The CASEX averaged 11.4 years of addiction-related experience. Our team has proven to be adaptable and solution-focused, as shown by their quick transition to full telepractice during the COVID-19 pandemic. Our staff are always looking for new ways to grow and learn. We have multiple bachelor-level staff that are currently their graduate degree. So they're always trying to, stay current in their field, in their work. Our team understands addiction, the pain it causes, and how to guide people in long-term recovery. But we're particularly proud of the work that they do. Our treatment philosophy has evolved. It's not in there? You can't see it?
We can see. No, you've got your slideshow. You've got your notes, you got the slideshow.
Okay.
There you go.
Where is it?
If you put your slideshow back up.
We can see you now.
Start the slideshow. Don't show the notes.
Don't show me.
We can also put it up.
Hang on. I'm sorry. From beginning. Oh God. Then is it showing? Okay. Display. Okay.
Can we put it up?
Go ahead, Keith.
Oh, they're sharing it now. Better.
You've got it. Yeah, okay.
Can they see it now?
Yes. I think so.
Okay. So now I lost my place.
Take your time, just find your place, we'll wait for you.
slides, Keith?
Yeah, I'm trying to see where I'm at this point.
So we are at person-centered care, which is slide 6.
Okay, just a moment.
Is it up? I can't tell.
Okay.
To me. Yep.
Just say next slide when you're ready.
Okay. So our treatment philosophy has evolved because the New York State OASIS guidelines have, kind of changed the focus, and so we've moved along with that. So we have embraced the person-centered care approach to treatment. We provide strength-based treatment planning while utilizing methods that have been scientifically proven to be effective. We've learned that punitive treatment approaches no longer work. Back when I first, was doing this kind of work, it was very common for people who relapsed or weren't what they used to refer to as weren't particularly compliant or vested in treatment would get kicked out. We no longer discharge people for the symptoms of their disease, including return to drug use, even if they're on medication, engagement problems, and refusing treatment recommendations. We regularly see clients who have been administratively discharged from due to non-compliance, like I mentioned, and we know that being kicked out of treatment doubles the risk of overdose for clients. So we really work to stay in it with the client for the duration, working diligently to encourage them and engage them to give them a better chance at recovery. Significantly improved our client engagement through utilization of peer services. And can you hear me?
Yes.
Yes, we can hear you.
And we attribute our use of peer services and telepractice to our no-show rates. Our no-show rates were of 30% and we're down to 12 or 13%. I hear echo, that's why I asked. We have also improved our coordination and collaboration with referral sources, provided increased amount of physical and mental health services to provide more comprehensive care to our clients. Next slide, please. So we obtained our telepractice designation in 2018. Immediately, it became available or allowable for behavioral health agencies. This really put us ahead of the other providers in the area. We were able to transition to telepractice services when the COVID crisis began for preparedness. We also provided assistance to other area providers during the crisis. Recognized for our success in telepractice, we've been awarded the 2020 Outpatient Telehealth Innovator of the Year Award from North Country Telehealth Partnership. We recently completed a virtual site review utilizing our telepractice technology. It was a very good review. Everything turned out wonderful. And during the exit interview, the reviewer from OASIS described our work in preparation and planning pre-COVID for telepractice as brilliant. Our telepractice visits have increased from less than 3% of our business last year to greater than 69% of our business this year. And our total number of visits are up by 31%. You can see that on the slide, a little grid. You can go ahead and So to share with you kind of how we got through this process and prepared for this, I think it's important to understand that we did do a lot of footwork to prepare for this process. So, essentially we did our homework. We sought out providers, including Sisters Hospital, which you guys heard from Dr. Updike, and they've been providing OTP since 1970. I don't know why that. I can't mute myself. Their Buffalo serves 988 patients, the Rochester serves 300 patients, and the Amherst is more of a more suburban town. They serve 266 patients. But we modeled our clinic after the Amherst site because that's similar demographics and a very similar size area. Dr. Updike Brown, clinical director there, provided extensive providing us technical assistance in this process. Also, Cradle Community Center, which you've heard from as well, provided us with technical assistance. They opened their OTP in 2016 with a census of 30, which is what we're proposing. Now treat 210 clients. Jay and I were to be able to go do a site visit at Credo in 2019. And we were able to spend some time with the staff, check out how the OP operations work, and see the dosing and the equipment that we proposed, how it works. Both agencies did advise us on workflow, program logistics, billing, OTP specific policies and procedures, staffing, and equipment. We also received technical assistance from Greg James, who is the New York State Addiction Medicine Advisor from Oasis, and he assisted us with like safety and security, also the equipment and the floor plan. He reviewed the floor plan that we proposed as well. He also did help us a little bit with the policy development. We did utilize SAMHSA, the U.S. Substance Abuse Administration, for interpretation of some of the federal guidelines, and we did constantly review the federal and state guidelines that our plan met the requirements. Also, we did meet with our landlord, who obviously helped us with the floor plan to develop the floor plan and what the changes would be to meet the requirements. They can change the slide, please. I'm not sure why they didn't go, but. So you can change, you got it. So the COSAP requirements, I was heavily involved in the application process for the COSAP grant, so I'm very familiar with what's required and what was proposed. So St. Lawrence County applied to the Comprehensive Substance Abuse and Stimulant and Substance Abuse Site-Based Program, COSAP, seeking a total of a $900,000 award from the Department of Justice. A large portion of those funds are designated for the OTP project if we're awarded. If the county is awarded, they will enter into a federal contract and maintain fiscal and reporting responsibilities for the program. Community Services, we feel, is in the best position to successfully deliver and administer this program. The county itself would provide direct oversight for program delivery and drawdown of federal funds, ensuring that the program expenses are offset by federal funding. Our extensive grant funding history, we have a system in place to complete government reporting, which is required to remain compliant with these government contracts. Reporting is complicated and time consuming. I can tell you it's taken a while to master it, but we have. It could be held liable if the reporting is not completed in a timely and accurate manner. You can change the slide, please. I'll try to give you a quick overview of what our program implementation looks like. Our overall mission and vision, very simply, we want to provide full agonist specialized treatment for individuals with opioid use disorder. Our staffing plan was developed based on the recommendation of our mentors, combined with the requirements outlined in the federal guidelines. Our staffing is based on a startup of number of 30, and we would need to expand the census as the census expands. Dr. Updike advised us to not break the bank by overstaffing initially. He suggested adding staff as the clinic gradually grows. Mission requirements, very similar to the previous folks, that the individuals need to have an opioid use diagnosis. They need to have a use history of at least a year, medically stable and willing to participate in treatment. We also, high risk populations such as IV drug users, women and folks with communicable disease, health issues certainly will be prioritized. Discharges, again, this falls along with the person-centered care Right now, anybody that leaves treatment, it's done, they're given a discharge plan. We do it collaboratively with a client. Very rarely do you see an administrative discharge anymore from treatment. If there was an administrative discharge, it would be subject to due process, and our medical director ultimately would make the final determination. Being a person-centered program, we really want to work to exhaust our efforts to keep clients engaged, because we know that the outcomes aren't good when they leave treatment early. You can change the slide, please. So our medication dosing will be 6 days a week from 7 a.m. to 12 p.m. We determine these hours based on when we talked with the other mentor agencies, but we also looked at the demographics, our patient load. And so our MAT clients, only 20% of them are currently employed. So we didn't think that really early morning hours was feasible. Also, looking at Medicaid transport, I know that some clients, if they have to go to Burlington, be there early in the morning. Medicaid, it's hard to get Medicaid transport, particularly early in the morning, because with the weather, if the roads aren't plowed, the Medicaid rides cancel on them. So we tried to cater it to after the roads are plowed and folks could be out. Technical assistance and our mentors suggested we adjust the hours as the clinic grows. As it takes on and more people get involved, then you see you have more working folks, then you would adjust it and add earlier hours if you needed to. The picture on the left shows the IVEC pump. It's like that silver box below the computer screen. And that's what it looks like. So it's very small, like a bread box. Methadone, electronic pumps, it's considered the gold standard in the OTP world. They reduce the risk of human error, they reduce the risk of diversion, and they speed up the dosing process. At the clinic all day waiting in line. A client would present their ID and scan it into the EHR, and then the pump releases the proper amount of methadone. There's no room for human error. We did not consider using tablets as they require dissolving in water, which is slower and creates a risk for diversion. The picture on the right shows a similar type ballistic grade window. That's what we had budgeted for. Just to give you kind of a visual. You can change this, please. So this is our floor plan that we looked at and proposed. We looked it out in collaboration with our OASIS OTP Technical Assistance Office and reviewed it with our regional facilities inspection from OASIS. We kind of designed it so the dosing traffic was designated with safety and security in mind, and the clients are separated and not passing by each other after dosing. Adequate space is available for counseling and medical services. As you can see, the location is fully furnished and operational. Our landlord happens to be a contractor as well. So it was very easy for us to discuss with him the modifications. You can see them in the red, the modifications. It has actually some of the materials, like there are some certain materials for the safe room that require really, it'd be proof, like you couldn't hit it with an axe and get through it, the wall materials. So he has those materials left over from the really secure ice building next door that he built. And so he said that he would reuse those and only charge us for the expense of the ballistic glass and some minimal labor at his cost, which would be a couple $1,000s. I asked the landlord how long these changes would take, and he said the actual construction modifications would take less than a week, but he does know that it takes up to 8 weeks to get the glass delivered, so that could slow it down. He has, installed that sort of glass in other municipal buildings. For our safety and security, we went with a comprehensive security system locally by NCC Systems. It's who we have used before. And we did talk with our technical assistants at OASIS about the security system versus a security guard. And in speaking about the demographics of the town and the size of our initial startup, they didn't see the warrant for to bring on security guards. So we went with a security system, and it's extensive. It includes internal and external camera, I've mentioned that the dosing window is like ballistic. So if someone punched it or shot a gun on it, God forbid, it would be, you couldn't penetrate it. The safe is wired with right in the security system. There would be panic buttons and all the doors and windows are alarmed. This location really, well, there's a lot of different reasons why we picked it, but it's centrally located in walking distance from most of the major neighborhoods and is on a regular stop on the Messina bus loop. They have like a loop that goes around all day long. Also that the Messina PD is only 0.8 miles up the street from the clinic. So, if they're in the event of an emergency, we have quick access to support. You can change the slide. So in preparation for this project, one thing I didn't mention in our homework page is we did an OTP policy and procedure manual. The OTPs require some specialized procedures to meet state and federal guidelines and the DEA requirements. So having this manual prepared helps us to be able to quickly apply for licensure if we're chosen. Set to go and buttoned up. I mean, we had clinic operating procedures, but we did not have OTP specific procedures. You can change the slide. Actually, you can go 2 slides. Yep. So I'm just going to quickly show you some highlights of our budget. I know I'm running long, so I'll try. The current plan is to repurpose existing staff. As I mentioned before, the staff that we are staffing conservatively, knowing that initially we'll not need, a whole bunch of staff, 30 clients. So due to our telepractice capability, we are enough to share staff currently between our clinics at whatever site is needed. So an example would be initially like a counselor would not have a full caseload because we're just, ramping up. So we have some telepractice clients from our other 822 clinics to fill their time and meet the needs of the clinics. It's definitely an asset for us. You can see our staffing pattern, what we're looking at. You can advance the slide. Okay, our operating expenses. Good things is that this is actual expenses. This clinic is, there's no guesswork in these figures. We know this is what it costs to operate this clinic. There's no hidden issues or bills that weren't considered. So this is what we're currently paying for the expenses at this site. You can advance it. So we selected our OTP specific equipment based on OASIS technical assistance and our mentor agency's recommendations. Jay and I had the opportunity to see this equipment in use when we visited, and it was easy to see how efficient it was and how safe it was in their practice, using the liquid and how they did how their window and everything was set up. We were able to see, that it was very safe. You will see the EHR line is highlighted in red. We wanted to let you know that our funding, we have secured funding elsewhere to pay for the EHR, so it would be from this budget, and that would bring our total operating expense down from $276,000 to $98,441. You can advance it. So when reviewing our application, you may have noted, I really wanted to have backup. I know working at the county, I always have to have backup for everything, right? So I wanted you to be able to see, how we came up with these numbers that we just didn't haphazardly say, this is what we're gonna make. So we tried to be very systematic about it. So I added tabs on the Excel sheet to show exactly how we determined our revenue. We looked at the number of visits, and then we used the APG calculator. And we also got recommendations from our mentor agencies, and we combined that information with the minimum regulatory requirements. So it's not an inflated number, it's very actual. On the bottom of the slide, I saw kind of an error that I made in the proposed, and is that, I didn't take into account, what Dr. Updike was harping on us, just build staff as you go, and our census, would be up to over 100 by beginning of year 2. So we added the expense of 2 FTE to kind of even that out and make sure that we had enough staff to cover the census. So that would really bring our expected profit down to $523,000 on the second year. Go ahead and can advance it. So I just wanted to show you kind of how my backup worked. So the ambulatory patient group calculator, APG, it determines the reimbursement rate by weighting the different types of visits. And this is what Medicaid and managed care has to pay us. So it's pretty on point because the majority of our clients are Medicaid or managed care. So we were able to determine, we came up with how many visits per week there would be for dosing, and then from there, what Credo and what Sisters Hospital, generally sees with new clients, how many visits they have, and that's how we came up with the numbers. You can advance it. So the other thing that I've had a lot of questions about is like, well, OTP is going to be profitable now because COVID, and they're giving them all these take-home doses. So I want to kind of just explain how that works. So due to COVID-19, there was some rate adaptations released by Medicaid to offset lost revenue because they were letting clients take long take-home doses. So, those were why I got the questions, right? And so this enabled the new rates, the bundled rates enabled OTPs to remain solvent during the pandemic and possibly beyond, because there's talk that the bundled rate will go beyond the pandemic. So OASIS kind of has told us that despite the pandemic, the diversion with these longer, take-home doses has not become an issue. They're like, surprised about that. And you'll see that one of the things like offsets it on a week that a client doesn't come to clinic at all, the clinic is still getting paid for their service. So say they had a 2-week take home, the first week they would bill, and get $207, for that week, and they're giving them, the take home doses. And then the second week they'd still get paid, so that hopefully they're offsetting. One of the assets that we have is that we would still be able to see clients because we have, an expansive telepractice program. And so even if the pandemic is worse or these things still are going on, we would be able to still, operate and see the clients via telepractice. If you can advance the slide. So lastly, we wanted to kind of make note, in the last year and a half, the CD clinics have been able to utilize $730,000 in grant monies. $330,000 of these funds were competitive awards to enhance, expand our addiction services. So if there was money out there, we went after it. If the COSAP grant is not awarded to St. Lawrence County, we feel that we can continue to move forward with the development of the OTP operations. Without the COSAP funding, we project needing approximately $50,000 in additional funds, mainly for specialized equipment, and that is not budgeted, or that is not currently in our tentative 2021 budget. The staffing expense is tentatively in our 2021 budget, but the specialized equipment is not. And the next slide is just questions, to see if anybody has questions. I know I have a lot of information and talk fast.
Are there any questions? Go ahead, Mr. Burke.
Shana, you spoke of mentors. Who are the mentors, and where did they come from, I guess?
So the two agency mentors were Sisters Hospital in Buffalo, which was and Dr. Updike's clinics, and they operate 3 OTPs. And then we also utilized Credo, which they spoke, to the board. And we also, had a technical assistance person to us through OASIS. So he was heavily involved in looking at the floor plans and making sure that we had a proper security and such. So those were the 3 main players in it that helped us the most, I would definitely say. We did lean on them quite a bit, and they were wonderful helping us develop policy procedures, tell me if I'm wrong, or main players there. But there were some other supports we did utilize.
Could you talk just for a minute about the security of the dispensing, the liquid dispensing? I guess part of the presentation, regrettably, there was quite an echo, and I'm not sure that I caught it all, or did other people catch it either. But if you wouldn't mind talking about the liquid dispensing and the security of it.
Okay, so how we laid out our nurse's office is only the RNs really have access to that space. And within that space is a smaller room that has the medication safe. And then the liquid bottle of methadone, is taken from the safe when they open for the day to the IVEC pump. And then when a client comes in, each client has an identification badge, and at Credo, a lot of the clients kept it right there because they tend, people lose stuff, right? So, and they use that identification badge to show that's the actual client as a picture, they know it's them, and they scan that into the electronic health record, and then immediately the electronic health record knows the proper dose and dispenses the proper dose. And then the client would drink the liquid, and then they would pour water back in the cup, swish it around, and then drink the liquid. So there's no chance of diversion, any methadone leaving the clinic, anything going in the garbage, that sort of thing.
Another follow-up, if I could.
Yes, go ahead, Mr. Burke.
You indicated that, and again, I didn't catch all of this, but that you regularly see patients who were administratively discharged. Could you go over that just?
Well, there are some agencies in our area that administratively discharge folks for missing too many appointments, not complying with the treatment recommendations or the level of care. Maybe they're continuing to use, very commonly it's meth. And so they get asked to leave essentially. And then we end up with those clients on a regular basis, and we try to make sure that their needs are met. And if they're not doing the best, we continue to try to engage them. We assign them a peer, and we try to intensify their treatment as much as possible to meet their needs.
And why do we do that? I mean, why would we see people who may not be interested in follow through?
Well, I mean, it's part of the nature of the disease, in the recovery process, the stage of readiness, often the clients aren't ready and they can't find it within themselves. So we really take pride in working to help them find that intrinsic motivation and support them, because when they're using drugs, they're not thinking clearly and they can't, help themselves sometimes. And so that's what we're here to do.
And the ramifications if we didn't?
If someone's kicked out of treatment and they're not getting treatment elsewhere, their chance of overdose doubles.
Thank you.
Ms. Kern.
So, hi Shana, thank you for your presentation, I appreciate it. So the number of people that we're serving, community services is serving right now, I think on your first slide, is that more than 2,500 that I see?
That's total unique individuals we've seen in 2019.
2019, okay. Because I noticed we're seeing about 700 people a month. So out of that 700 people that we serve, we think we have 30 that will need this program?
I was looking at our MAT census, and we have 80%, which is 100 clients that are on 7-day scripts or less. So that would, quickly lead me to believe that we could easily fill starting census at 30 just from our clinic. Now, obviously, the other providers also have people that are failing miserably on partial agonist medicine, but our clinic, I know we have enough people to just open the.
Right, and so.
Go ahead.
So in all the presentations that we saw, they recognized that there would be a significant loss the first year. Community services has been having a significant loss already every year. So we want to add to that another significant financial loss that the taxpayers can be.
This program, our proposal does not see a loss because the revenue generated is much higher because of the intense level of treatment. So regular outpatient reimbursement has not changed in 10 years. So maker, it's not a profit maker. If it were, everybody would be doing it for profit like they do in Florida. It's just not a moneymaker. OTP, and it's not really in my mind about the finances, but OTP is an intensive level. And right now, you know, they have a 10% increase on their APG rates to incentivize programs. So it is more of a moneymaker than regular outpatient. Unfortunately, I hate to even talk like that because it's really more about the clients and the people.
Mr. Lightfoot.
Good evening, Sheena. Thank you very much for your presentation. I too had a little bit of trouble hearing you. The acoustics are not that great. What do you see are the elements that make the county program more attractive than the other two presenters this evening?
I think that we probably are the most prepared. We really put a lot of work and time in this. You know, the whole concept of OTP really came from Jay and I over a year and a half ago. We talked to, you know, CSB about it. We knew it was a need. We identified it and we asked for it. The state approached us as the county providers and said, you know, will you do this service? It's a need. And, you know, you guys are safety net providers. You've always been the safety net providers. You know, and so they had approached us about it. You know, we have a really experienced staff, you know, with high education, and they're all credentialed. I would think the other thing, you know, we really done our due diligence to prepare, but I think that it quickly and easily transition to this. It's not a huge construction project with, you know, lots of wait time and that sort of thing. And the other thing is that I put up a slide. It showed that we received $225,000 for our mobile clinic. The state actually asked Jay and I to talk to them a little bit about that because at the city during COVID, they found that mobile clinics were utilized to provide methadone services. And so they wanted us, before we purchased the vehicle, to make sure that our vehicle was properly secured in case that is something that we need down the line. So I think that that is an asset for us.
If I may follow.
Go ahead, follow up, and then Kevin right after that.
It's more or less a new question.
Okay, go ahead.
Okay.
Sure.
Sheena, how does the program survive once this seed money or this grant money goes away? We're looking at now not getting 100% of what we are billing for. I'm told the figure is somewhere around 80%. When that grant goes away, what happens to the viability of the program?
So I had mentioned before, and I hate talking about money, but the OTPs generally don't need or receive state aid because they operate in the black. And, you know, we have talked, obviously we have mentor agencies that we talk to, and they are operating in the black. We confirmed that. Dr. Updike says that their OTP is second in revenue to their surgery unit. So, you know, it is anticipated to be self-sustaining. The state says it's self-sustaining. You know, the agencies we've worked with say it's self-sustaining. And if we did get the COSAP money, a lot of our overhead would be paid for 3 years. There would be a serious problem with us if we, if we could not come out on top with that startup. It really would set the stage nicely for, you know, really succeeding.
Thank you.
Mr. Akers.
Thank you. Shana, thank you for your presentation, and also congratulations on the award that you received that your staff put in for you. I think that's quite an honor. I'm not familiar with the Harrogate building. What goes on there? Is it totally our building, or we're renting this, or what do we got going on there?
The Harrogate Commons, it also houses probation department, and it has a emergency, I think it has an EOC center in it as well, and the DMV as well. Our operations is like what I see is the back of the building. But
So do you think like the entrance, like the stigma has been mentioned in both the previous presentations, do you think that could be an issue, or it's a separate entrance?
Well, I mean, a lot of people, the reason why the bus line goes there several times a day is because a lot of people access that building for a variety of reasons. whether it be the DMV or they're on probation or they come to us for clinic. Many of those people are already accessing the building, many of the people that we would have, and, pass by each other and don't know what their business is there. We would propose or prefer to have a separate entrance, just because we think that it would be more discreet, and just make the other departments feel better, I suppose.
Okay, so the second question I have is, St. Lawrence Health System said they've been in the addiction business for 35 years, St. Joseph's 49, in the county 40, and this is a reference to people being discharged. Are the other two entities, are they actually discharging uncooperative substance abuse people?
I wouldn't want to. I don't know how I thought I would want to answer that. There are only us, Citizens Advocates, St. Joe's, and St. Lawrence Health System as game players in the outpatient world. And so derive from there that perhaps some of them may be administratively discharging folks, but I don't want to talk ill about anybody.
Mr. Ross, would you like to comment about your procedure?
We are committed to having our residents and our outpatient clinic clients receive the maximum amount of support that they possibly can. From time to time, there are individuals who make the decision themselves not to continue services. We do our very best, Dr. Biaggi and all of the other people at St. Joe's, to try and convince them to stay. If we have an administrative discharge, it's not for the reasons that were mentioned before. If we have an administrative discharge, for example, in residential programs, it's if somebody is being physically abusive to another client and it's not safe. So I won't answer about anybody else's programs, but in terms of your direct answer to us, we do not routinely have a situation where people leave because they've been administratively discharged. They most often leave because they don't want to continue in services. And we, even after that, will take them back and do everything we can to engage them, because that's what our responsibility is.
Okay, thank you, Mr. Ross. That's all I have, Chairman Sheridan.
Ms. Kern.
So, sorry. I'm sorry, this is Jamie Smith. I just wanted to make sure that we had the opportunity to respond to that as well. I would like to echo that administrative discharge is an extremely rare event per OASIS guidelines. You have to really, it's a huge decision that has to be made within the context of the treatment team. It very rarely happens for us. And like Mr. Ross indicated, usually that's only in cases of physical violence. And we always do look to readmit people should something like that occur. Thank you.
Okay, thank you. I didn't realize that you were still on, but thank you for answering that. Thank you, Mr. Sheridan.
You're welcome.
So a couple follow-up questions. You mentioned that a separate entrance might make some of the other departments in the building more comfortable. Are they not like really thrilled about the idea of having this in their building? I know they share the building with the Department of Motor Vehicles and Probation.
I mean, I haven't spoken to the DMV. I just think this is the reality. In recovery, a lot of them smoke, and although smoking is not permitted on our property, they do, and police that constantly. So I wouldn't want them hanging out or whatever. Loitering is something that's an issue at OTPs, so that's a priority to have it not happen, and that's why there's a dosing schedule. But it just would. Nobody's complained. Nobody said the DMV didn't say they, either way. I think probation. We work wonderfully with probation. So I don't think they would mind per se, and it actually probably makes their life a lot easier not having to worry about diversion of medicine. So I think that it would make their life easier. I just think it would be a little more discreet because those things do happen, like smoking, and I wouldn't want to have the other department, put out by that.
No, sorry, Mr. Sheridan, sorry.
Go ahead, Rita.
So when Credo was here to present months ago, They talked about the fact that they in fact lost a lot of money every year and that they have a payment system that they get from the government. When you look at their 990, it's pretty evident that they lose money, and they did tell us at that time that they get a special grant to fill that void each year because of the fact that they are something that they deem necessary in the particular market that they serve. So in that case, we know that they don't make any money, and I don't know, I'm a little worried. Although you hate to think about this in terms of money, we have to think about this in terms of money because we answer to the 111 or 12,000 people that pay taxes in this county. So we have to look at what the best way to do this is.
Right. Jay and I did look closely at monies, and they receive deficit funding state aid. And so they put some expenses on their budget that we, in order to receive the state aid, like, we saw a $100,000 finance firm, to help them. They pay, I think it was $165,000 for billing. That is, they have multiple programs overall, but the OTP to maintain their state aid, their funding is, we would assume it's moved around in that way to maintain it that way. But they still showed us, we looked at it, they still showed us a profit.
Any other questions?
I think Margaret's got a question.
Margaret, go ahead.
Thank you very much. In terms of it being in the black every year, what would be the incentive for St. Lawrence Health Systems and St. Joe's to want the program if it were going to be something that ran a deficit every year?
Well, being in the black is not a deficit. Being in the red is
No,
a deficit.
I understand that. I mean, what I'm saying is I believe that it probably does make money, but why would an agency other than yours want it? And you probably can't answer this question. This is more of a general question. So I can understand how you would want to have a program like this because it is a moneymaker, wouldn't it? Yeah. Do you
It's
follow me?
sustainable. Yes, absolutely. It is sustainable. The tech assistants in our regional office, and Dr. Updike and Credo, they have all, explained to us that it is sustainable and does well. Yes.
Okay. Two other quick things. Did you say 20% of your patients are employed? Was that correct?
Yes.
Okay. And tell me a little bit about, you mentioned that you were highly prepared to go into telepractice. How did that come about?
So what happens when there's a new regulation proposal comes out, it comes out multiple months before. And so we saw that they were proposing to have telepractice available for OASIS providers. So I had prepared my, my plan and everything, and immediately when you could apply, we applied and we're set up. I also wrote a grant for technology. So we received 15 plus 40, so $55,000 worth of technology grant monies, so that all of our clinics are outfitted perfectly to do, telepractice. So we had the equipment, and we were already designated by the state to provide that care, and we were providing it, but on a much smaller scale. I think on the slide it was like 100 and some visits in 2019. So it was primarily our prescribers that were providing that service. And at the time of COVID, our counselors had been doing a test client to do telepractice with, and they were doing it with the test clients. But then all of a sudden we had to turn the faucet on and have everybody do it all at once. But we had everything ready. We had all the equipment and the policy and procedures ready, and the staff knew how to use it. So, I met with them and then said the next day we're going live in telepractice, and they were able to do that. A lot of agencies, when I, participate in the regional OAS or the ASAP calls, which is like an advocacy agency, a lot of agencies weren't able to transition quickly. And, there are some agencies that couldn't transition at all and still just do telephonic visits during COVID.
And are you finding that you've got better compliance in terms of people keeping appointments and because of telepractice? Has that been a finding of yours?
Absolutely. Our no-show rate, I'm sure you've seen it, is down the lowest it's ever been, like 13, 14%. It was upwards of 30 in-person visits. The pressure of clients to not have toxicology testing every time they walk in the door is reduced. Plus just getting rides. They've got kids, they've got, different things. They don't have a car, some don't have a car, Medicaid rides don't show up sometimes. All those barriers were lifted. And one of our peers is particularly skilled at getting loans for the clients and getting them set up with Zoom so they can telepractice. So she worked her tail off trying to get everybody set up. So, all of our visits are telepractice.
Thank you very much for answering my questions.
Mr. Burke.
The two entities, St. Lawrence Health System and St. Lawrence County, that presented a budget, both showed significant profits during the second year of operations. I mean, it's anywhere from $500,000 to close to $1.5 million in profits. So how anybody would come up with this being a potential liability cost-wise to the taxpayers is not based in reality. And again, the estimates that were given, the number of patients that were initially going to be seen were pretty conservative estimates. So this isn't a liability for taxpayers. This is much like motor vehicle. It has the potential to offset costs where we consistently lose money in other areas. So it's not a matter of speculation. It's more a matter of being able to review what's been put in print by both agencies. And I can't imagine why St. Lawrence Health Systems or St. Lawrence County would want to somehow inflate their projections of revenue. They're both entities are far too reputable to do that.
Any further questions or comments? Okay, thank you very much, Sheena.
Thank
Nice
you.
presentation.
Sorry about all the technical problems.
Well, that's something we can't control, and neither can you, I guess, so you did well.
Thank you.
Thank you, everyone, for your presentations.
Thank you.
I suppose next thing we could talk about in terms of the presentations is maybe we'll take this up with the Finance Committee next Monday, Kevin, and digest what we've heard tonight and come up with some sort of resolution. So next on the agenda, if Jay is available, we have a, you are? Okay, Jay. We have a resolution that's expanding the impaired driver program into Franklin County and modifying the 2020 budget for community services. Do we have a motion? Mr. Perkins makes the motion, seconded by Mr. Forsythe. Go ahead, Jay, you can discuss this, please.
Okay, good evening and thank you. As you know, we do have the IDP program in St. Lawrence County, run by Special Programs. That impaired driver program is for individuals that are convicted of driving while intoxicated offense and needed to go through a 7-week, 16-hour course in order to get a conditional license so that they can remain employed. Currently, we're projected, well, our original budget for 2020 was $36,000 of county cost. The projected budget is $34,601 moving forward with our projections for the remainder of the year. Approximately in mid-July, we got contacted by the program director in Franklin County, who has been doing this program. She's a private contractor. She does not work for the county. It was not a county operations, but a private individual. She is relocating out of the state, and approached us if we had an interest in, developing the program in Franklin County. So me and Michelle James, the special programs coordinator, we started doing some research and putting some numbers together. And of course, the projected budget for this particular expansion is a little difficult to be 100% accurate because, it depends on the courts and how fast they're processing these convictions in times of COVID. But, we did our best, and, we feel that it has the potential to cut the county cost for this one particular program, which is a fee-for-service program. There's no grant money attached to this, to lessen the county costs, but also expand the needed services in the Franklin County. There was an issue with trying to find an adequate venue or space to hold the classrooms. It's my understanding that she had an arrangement with North Country Community College, both in Saranac Lake and in Malone. For a minimal fee, they allowed her to use some classroom settings to have this place for the courses. I talked with Joe Keegan, the president, and he ran it by his administrative team. Because the students there are not allowed on campus for the most part, they didn't feel that they could have public members at large participating in this program. So we did a search, we looked at some fire halls, fire stations, but we ended up securing a conference room at one of the Citizen Advocates building at no cost. The room, they thought with distancing, it would hold about 23 individuals. We have found when we went, or when Michelle went on site, we thought it was more, maybe like 14 to 16 individuals. But nonetheless, it was an adequate space and would allow us to move forward with this expansion. Additionally, we have 2 instructors, plus Michelle also does instructings for this program. But one of the 2 instructors that are part-time, one of those was not comfortable doing face-to-face during COVID-19. And the DMV in Albany does not allow any remote or virtual classrooms for this particular program. So in addition, and even if we weren't having to expand, 1 instructor plus Michelle would really leave us a bit short if someone had a conflict in their schedule or took ill. So in addition, the resolution, speaks of hiring a 3rd instructor, to round out the needs of this program, whether we expand or not.
Any questions, Jay? Mr. Akers?
So Jay, would we be sending an individual from St. Lawrence County to that site?
Well, I mean, they would certainly have choice. Like if they worked in Franklin County and were already there, but we would not be sending them there. We would be working with the DMV in Franklin County to get the referrals necessary, to get a critical mass to have the group. Currently, we have about 3 individuals that are traveling to St. Lawrence County because there's no class in Franklin County.
Oh, okay, I was wondering like the $68 for fuel charges. So I was trying to equate with that with sending an instructor into Franklin County. So what would the fuel charges be for then, Jay? I realize it's a small item, but I'm trying to get a grasp of what you're trying to do here.
Well, we would be using the county car if the instructors chose to use a county car. Understand that, one person lives towards Franklin County, and it wouldn't be cost effective for that one instructor to come back to Canton, pick up the county car, and then drive to the Malone area. So that person would have their personal vehicle, which they would not get reimbursed mileage for, but that would be their choice.
It doesn't seem like $68 would cover very many trips. I mean, it'd be multiple trips, would it not?
Well, each class is
$16.
Yeah, it's seven classes. So if we did, one class this is a 2020 budget. So if we did one class to end the year, I mean, there is a possibility we might do a second class, but it's more probable that we would just be doing one class before the end of the year.
Okay.
Did we answer your question, Mr. Rick?
Not really. It doesn't seem like we
Well,
covered much my.
well-
It just doesn't seem like $68 would go very far. I think I'm missing some part of the concept, but I understand what you're trying to do. I just don't know where the 68 bucks is, how far you're gonna get, you know? Is that like buying hay for horses or something like that, you know?
Point taken, but it would be round trip for 7 classes.
Okay, from say like from Canton to Malone, or from where? From where to where?
Yeah, from Canton to Malone, round trip, 7 classes.
I think you're missing a zero, I think, at the end of that, but whatever. I understand, go ahead.
Any other questions? No questions on the screen? Okay, all in favor?
Aye.
Opposed? Carried. Jay, stay on. We gotta have a discussion on, the state opioid response SOAR grant, year 2 funding. You have anything on that?
All right. So it's, you know, it's certainly no secret that there was approximately 245, it turns out to be $247,000 that we had linked that with the development of the OTP operations in St. Lawrence County. That did not go quite as planned. And the due date for submissions to get that award approved or get that monies approved was September 29th. So, you know, after talking with St. Lawrence Health Systems, and they were standing down pending, you know, a decision by the legislatures, I quickly realized that there was not enough time for them to get the nod to do the OTP and secure the SOAR monies. So I had some conversations with the OASIS team and people that were overseeing, you know, the SOAR grant. And there was some concern that if we did not use these funds, that they would be put into a larger pool that would, you know, go to other projects. You know, for example, they recently released a regional project using some of the leftover unallocated SOAR monies. However, that RFA was subsequently rescinded for a lot of various reasons that I really don't want to get into here, because some of that's just conjecture in my opinion. But they were pooling unallocated funds together for future SOAR projects. So having a conversation with them, I had asked if, since we already had a contract with SOAR, would we have enough time to just amend our existing contract and utilize that money? And they said probably. And so we took quick action and came up with a proposal. Now, originally these SOAR monies, and what we planned to use the SOAR monies for was to cover the gap in revenue that the mandated peer for chemical dependency clinics, what her revenue is currently not covering, which is approximately $30,000. So $30,000 was allocated to covering that revenue gap. And then the rest, we asked OASIS if we could use those monies for an electronic health record. You know, originally when OASIS, you know, approached us for doing the OTP, they were willing to, I guess, bend the curve a little bit or bend the rules a little bit and allow St. Lawrence County to use the SOAR monies for an EHR in conjunction with developing an OTP. So then I went back to, you know, last minute when I went back to them and asked, you know, we don't know if we're going to be developing an OTP, but we're certainly continuing, you know, to provide addiction services and MAT services. Could we use that SOAR money for an EHR? And they gave approval. So we've been approved by OASIS and a man named Steven Sullivan. So we're waiting for, the final delivery of the sub-award agreement that would indicate that we definitely got approved. Again, they have till the September 29th, so we are coming down to the wire. So I'm just hoping that we got our submission in a timely manner enough to secure the money.
Any questions of Jay? Mr. Akers?
So Jay, of the $247,000 that was lost, how much do you expect to recover with your applications now? What they're going to allow approximately?
247 and $247,243 and a little bit of change.
You're going to be able to recover the total amount, the 247 of the SOAR grant then completely?
Yeah, we didn't really want to leave any of that money on the table.
Okay, thank you.
Any other questions of Jay? Okay, thank you very much, Jay.
All right, thank you. Have a good evening.
Wait just a second.
The monthly update has been provided as well. That clinic update, that was not on the agenda.
Do you have the clinical update? It wasn't on the agenda, but you may have it.
Should have it. It's in Google Drive.
Jay, it's in Google Drive, Jay.
No, I have it.
Do you want to discuss that?
Sure.
You got a question? Would you say a question?
Go ahead, Mr. Reagan.
Yeah, Mr. Chair, in the interest of time, could we put that off to next month?
Maybe better call the county attorney again, because I've been proved wrong already once tonight.
I think the county attorney said that it takes a majority vote to overrule the chair's decision, so.
I think I will oblige to your suggestion.
Thank you, Mr. Chair.
And no more further debate on that one.
Let's go in your file.
Okay, and now, the next item on the agenda for the resolutions are under the social services category. And it's modifying the 2020 budget for social services for costs associated with foster care and medical administration. And Cynthia Ackerman, our new commissioner, I think that she's on. This is the first time she's explained the resolution here in the Services Committee. Welcome, Cynthia.
Well, welcome everybody and good evening. So bear with me, I will do my best to try to run down this as quick as I can. So we've had, of course, as you guys well know, a huge influx in our cost for foster care. Our kids in care, the numbers have doubled. So we have had to move some funds around just to cover that cost. So if you look at the first item, if you see under increased appropriations, you'll see that copying equipment at $43,200. That number came from a decision was made that we were going to record the equipment, the copy equipment differently. So we were going to bring everything into admin, and then we were going to base our claims on staff count. So you'll see that number increase in the appropriations were down below. Excuse me, you'll see where we take that number away from there to move it up. So the next line, other fees and services, that number is grant funds under the code blue. So originally we had not budgeted enough money to put in there. We hadn't anticipated enough. So we have increased that funds where again, you're gonna see down below under the code blue for the decrease in appropriations, where there was where you have taken the $985 and we had subtracted well, if you look all the way down, you're gonna see that there's $3,832 under the Code Blue for increased revenue. That money plus the $985 under decrease is what's gonna, is what is shown now in the increased appropriations to cover the Code Blue. So we're gonna watch that too, because of course it always depends on the weather for this year. You know, we just can't anticipate that at this time. So we're gonna be watching that. The next one that you'll see under the DAG, the CCDS, and you're gonna see the co-location for chemical dependency. That's a contract that we have through community services. So there's plenty of money in that contract. So what we did is, you know, again, we're anticipating our uses, so we're adding a little bit more money into that funding to make sure that we're covering the costs. So the next one you're going to see is our FAR Flex Fund program. We have added funds in there as well for use. We didn't know how much we were going to use. So again, that was just an increase to cover the cost for that program so far. And we do have plenty more funds that we can appropriate into that funding stream if we need to. So the next one down is a DAM under the other fees. And that is through the LEA program, that's through public health for children. And just remember that the DAM fundings are 100% reimbursable. So we also make sure that that allocation matches what public health is showing. So it's kind of our checks and balances. So the last one is the institutional board, and you'll see where that's $1,170,000. That money is money that we have moved over from our MMIS funding stream. From the beginning of the year, our payments for Medicaid were $756,000. So since June 25th of 2020, that payment has decreased to $396,320. So the money that we're saving right now on making that payment is where the $1,170,000 is coming from, that we've been able to reallocate back into our foster care program. So then when you look at our decreased appropriations, you're going to see the equipment money, like I said, has come out of the units and it's all going into an admin. So we've covered that. We've covered the Code Blue. And we've shown where our $1.1 million in our Medicaid money is coming from. So you'll see down under the increased revenues that we have our general administration costs. So those are going to be our increased revenue. Again, the Code Blue at the $3,800, our chemical dependency at $8,300, and then our FAR Fund grant, which will be showing in our increased revenues.
Okay, I got so caught up in welcoming you here that I forgot to get the motion in a second.
Would you please repeat
So
that?
they won't always be this way.
So don't make me start over.
But I'm gonna have a motion, I need a motion and a second from Rita Kern, Mr. Perkins seconds it, and then we'll now go into discussion or questions of the new commission. Anything? You covered it quite well, Commissioner. All in favor?
Aye.
Opposed? Carried. Thank you, Cindy.
Thank you.
Next, authorization of purchase.
Before you
Chairman,
move on,
One more time?
I had my hand raised, you didn't see it.
No, I didn't. Well, go ahead and ask the question.
It's of our new commissioner. I just wanted to get a sense of her early assessment of need and you know, I heard her say that, or I heard you say, Cynthia, that our numbers in placement have doubled. What kind of challenges does that present?
So when you look at the increase in numbers, what I've been doing is I've been, having some lengthy discussions with the staff here. I've met with every single senior staff once a week since I've been here, probably some more than once. So we're trying to figure out what's changed. If we only had 150 kids in care a year or so ago, how come now we have, the 300 and almost 40 kids in care now? Several things have changed. We've had the whole turnover in legal, and there's, trying to play catch up, I think, from COVID. There's a lot going on there. We've had a changeover in our caseworkers. We have a lot of young caseworkers. We've discussed, are we going to court on what ifs instead of at risks? So we're looking at that. There's also a lot of procedures that they used to do that they haven't been doing probably over the last 6 to 8 months. And a lot of those have to do with review of cases. So, when we're, so back in the day, they used to do a 5 and under group where they, pulled everybody together for that team, for that child. And they talked about anything, under the sun, basically, that we could be doing, should be doing, what else there, what's out there, what type of programs are there, what other options do we have? So we're covering all the bases to make sure that we're supporting this child and this family to the best that we can. So we have restarted that group. We actually had our first meeting last week. We're going to be meeting on a weekly basis, reviewing all those cases. And with that, we're bringing in our YAP program, preventative services, to see, how many more preventative services we can get into those families to keep those kids out of care. The other thing that we're doing too is we're going to be reviewing all the foster care cases and all the institutional cases, and we're meeting for 2 hours on Thursday morning every week. We're going to start going over the top 10 cases of the kids that have been in care the longest, which on the 25th of this month, two kids will be adopted, and on the 1st of October, another child will be adopted. There'll be 3 off of our top 10 list. So we're going to keep going on that list to see what we can do different to get these kids out of care and back with their families, or revisiting the kinship program to see if, have we located, any relatives or anyone that could possibly not even realize that this child, was in foster care. So we're revisiting all those programs that they used to do that I think at least made some effect to keep those numbers down. And in the process of that too, we're also looking at, flow processes, where are our roadblocks, where are our funnels that are creating things to slow down, that's kind of pushing us backwards. I think if we were more prepared in court, we'd have more time to support the children and families. So we're looking at that as well to see what we can do to get the information flowing, to get, I call them the 3rd floor, which is, protective services, foster care, and our legal department. We actually meet as a team every Monday morning now for an hour to talk about the flow of the processes and what we can be doing better to support these children and these families. So I think there's a lot more engagement going on, which is going to bring out more information on what we need for staff training, what we need our staff to learn about. I think our staff in CPS need to understand more about domestic violence and all these types of things so that they can, kind of get more of a sense and understanding of what they're seeing, what they're involved in, those types of things. So I think I've kind of, and I've also been reaching out to a lot of other commissioners. I've probably spoken to 7 or 8 on the phone myself. I look at some data and I call them and I ask them what they're doing. What does their structure look like? What can we be doing different that we're maybe not already doing? What ideas do they have? So I am doing a lot of reach out as well. So I'm hoping that, this is week 6 for me. So I'm hoping as, time evolves, that we're going to develop more teamwork and really start opening the doors back up to, looking at more options for these families.
I think it's great that you're looking at your organization, but I guess I also wonder, in addition to that, are the presentations different? I mean, does the opioid problem, are there other things that you're seeing that cause the additional burden and additional concerns that maybe weren't there several years back or not there to that extent?
I definitely think that the opiate crisis has caused the numbers to increase. I think that's a huge factor in those numbers. And that's also said with other commissioners that I've spoken to. You know, we have we've been having children born addicted and different things like that. So, you know, and it really causes the parents to be, you know, disengaged and they're disattached from their children. So, you know, definitely that's a factor. Another factor that I think has caused it is COVID. I think that things had kind of quieted down because children were at home, and now that things are opening back up, we're getting more reports, you know, from schools and in different places where now the children are more visible. Maybe what's going on inside the homes, I think, is becoming more visible to people out there who are mandated reporters, or neighbors, you know, that may hear some things that are, you know, going on now that the children have been home for such an extended period of time. So those are definitely huge factors.
Thank you, Cynthia.
You're welcome.
Go ahead, Mr. Perkins. Excuse me. Second time I've done that tonight, Tony. Go ahead, Tony.
Well, it's okay. It's okay, Bill. It's because we both sit on the Trails Committee and you get us mixed up. But I'm wondering, certainly if not enough legal staff there is a contributor to this.
I've been doing a lot of research on that. I've been collecting a lot of data, and I do believe that the one thing I do see is I don't think that we have enough time to thoroughly prep for the cases that we have. I think probably more legal would help, but I also think that, like, the court calendar has been, you know, it's something that comes out like the day before. So how can you truly prepare for something when you only know a day ahead of time? Or, you know, like, for example, last Thursday we came in Friday morning to 2 trials that have been changed on the agenda, and one was scheduled for 11:30 in the morning. How do you even get your witnesses in on time? So I think there's a lot of factors, but I do think, you know, giving the legal more time to work with the caseworkers and really know that case, you know, to go into court and really present something for that child, you know, is something I think that's hindered by the big push and the flux of the children that we have in care at this time.
Okay, thank you. And thank you, Kevin, for allowing me to speak. Oh, I mean, Bill.
Yeah, touche. It's a compliment.
Tony Biden.
Go ahead, Mr. Reagan.
How many children are we seeing who are born addicted?
We've had one within the last week. And I think there's a couple pending that we don't know how it's going to turn out yet. But there's other children in the home, so we're aware of, you know, what could be pending. Or there's been other children taken away, and the web is insane. I'm sure you're aware of that. So we become aware of other situations that may be occurring. So.
Could you get us a report in the future at some point on how many a year that your agency is seeing?
Yeah, and probably along with that, I could probably add that as how many children are taken out of the home because of drug addiction.
Thank you.
Absolutely.
Any more questions? Thank you very much.
All right, thank you.
Good night.
We have another resolution here, authorization to purchase face masks for students in St. Lawrence County and modifying the 2020 budget for the Youth Bureau. Alexa, you have that one? You gotta move.
Hi.
Mr. Perkins moves. And,
Yeah.
Seconds it. And now let's have you talk, Alexa, and then we'll go into discussion.
Thank you. Yeah, so when our youth committee met in July, we discussed several initiatives that they felt, would be really important to be able to have. And one of the big topics that came up is that our youth wanted to really help students in St. Lawrence County feel more confident and comfortable in wearing masks throughout the course of the school day and ensure that students have access to masks as well. And after meeting with our youth advisory board, we wanted to be able to support that due to the fact that we know that there's a lot of stress right now with our school age students heading back to school in, this past September and having to wear them throughout the course of the day. And so we're looking at modifying our 2020 budget to be able to provide masks to students. Our timeline is by end of October. And so then our deadline is tomorrow by close of business day. We'll be pulling designs to vote on them between Wednesday and Thursday. So that way we can get them printed.
Your discussion, Mr. Lightfoot.
Alexa, how many masks will that money purchase?
Approximately 16,000. So that would represent students kindergarten, 16,000.
16,000.
Yep.
How long do you, if I may?
Go ahead.
How long do you expect those to last? What's the turnover time on those?
So these will be a cotton polyester blend. They are machine washable. And so they're pretty comparable to what we see most people wearing right now. And they're going to be soft, so they'll be comfortable for the students to wear as well.
Thank you.
You're welcome.
Any more discussion, questions? Okay, all in favor?
Aye.
Opposed? Carried. Thank you, Alexa.
I was supposed to say something about that,
Thank you.
about changing the resolution. I think.
Okay, we're going to vacancy review summary. Ruth?
Yes, apologies. We had at the Vacancy Review Committee on September 15th, we had 7 departments put forward 11 positions that you'll consider on this agenda, 3 departments, social services, community services, and public health. I did briefly want to mention with the authority that the board has provided to me to fill the 100% filled position or funded positions, probationary positions, or most recently temporary positions to respond to COVID-19. To give you an update so far, that total is 18. There are 10 in social services that have been able to move through, 1 for the board office, 2 in highway, and 5 in public health. So those positions, after conversations with the department head, have been able to move through the process and get that fill accelerated to assist the department with their work. With that said, I believe Cindy is still with us.
Are you on, Cindy?
I believe that she... Let me check. Let me check this.
We'll skip to community services. How about Jay with community services? We'll see if we can get you out of the way, Jay.
Yes. So this is a vacancy authorization for the additional instructor for the IDP class I spoke about earlier. Again, we do have 2 instructors in addition to the program coordinator, but one of those does not want to work during COVID. And of course, it's hard to predict how long that will go on. We are, running classes. They are back up in St. Lawrence County. So we're anticipating needing a 3rd instructor just so we have the capacity to continue providing the services.
Any questions? No questions of Jay? Do we want to go with Dana next?
Yeah.
Dana, go ahead. Are you with us?
Yes, can you hear me?
Yes, we can, Dana.
Okay. Our position is for a service coordinator. This is for the EI program, which serves children 0 to 3 years of age. For the last 2 years, we've seen a rise in the amount of kids that we see through this program. We currently have a caseload of about 155. And so we actually have enough caseload to just support just an extra person. The caseloads that people have been seeing have been a lot higher. And just even through COVID, while services have stopped for a few months, they have restarted. Some are done through the telehealth, but we are making the home visits at times. And because of the cease we had for a few months, we do have just more of the new referrals that we do need to see as well. On the child side of the department, we also have the children with special health care needs, and that's a grant program that with more staff in our department, we would also be able to get more resources out to the community. So this is what we're asking for at this time.
Any questions of Dana?
I believe Cindy's back on also.
Thank you, Dana. Thank you, Dana.
Yes,
There's no
I am.
questions, I guess. Go ahead, Dana. We're talking about filling the caseworker position, Children's Services, and filling the senior clerk position, Children's Services. For the
Okay, so-
vacancy.
Yep, so first I have the caseworker. So we all know how important this position is. You know, this position works primarily with children and families as identified by the Child Protective Services. You know, this caseworker provides preventative services to prevent out of the home placement, which is what we're really working on. You know, these caseworkers provide case management services for high-risk families. They provide continuous assessment to ensure the children are safe with no risk, ensure state mandates, contracts are completed, and make sure the court requirements are completed. This includes visitation, travel, you know, making sure that they're in court when they need to be in court. The current case holds right now are about 12, with the highest at about 17. So to not fill a caseworker's, one of these caseworker positions would then push all the cases back onto the other caseworkers, which then puts them beyond that level 17 in cases, which then really pushes them out of that, the ability to really focus on the families, and it really puts our children, you know, in the likelihood of serious injury or fatality. So I'm asking that we are able to fill this caseworker position. The second one, oh, go ahead.
Oh, go ahead. Go ahead on the second one.
Okay, the next one I have is a senior clerk. And this position is also vital to our visitation schedule. This person is responsible for arranging and also ensures the cost of transportation is at the best cost it can be for that transport. They make sure that the foster care, the kids in care and the parents are able to have their visitations per the court orders. For example, just in August of 2020, there was about approximately 350 rides arranged by this staff for the clients. So I'm asking that we are able to fill this position as well to ensure that we are in compliance with the court orders.
Thank you. Questions? Okay. Thank you very much.
Thank you, Cindy.
Thank you. Okay. Move on to committee reports. Mr. Akers, do you have anything on the Board of Health?
we met last Monday, we were supposed to meet at 6 and we met at 7 and I gave blood at 7:30 in Madrid. So we basically talked about feral cats in Waddington in the 20 minutes that I was able to attend the meeting.
Yeah.
I suggested giving a pellet gun to every 13-year-old in Waddington. It just didn't go over well. So Dr. Healy said he had nothing against cats. He couldn't eat a whole one. I mean, that was his joke. I thought that was a pretty good one. So that's it was mainly on the COVID.
Okay.
After I left, I believe.
Thank you. Mr. Lightfoot, you have a comparable story when it comes to the CBP Board of
Not
Directors?
that, and month of Sundays, and I have no report for this evening.
Good. Thank you, Mr. Lightfoot.
You're welcome.
Community Services Board, Mr. Akers again.
Well, I think do you want me to go in what we went over here tonight? I think that's
If you have a comment you want to make about it, fine, but
It was a nice presentation by all three groups.
okay.
Appreciate it. Well,
Good.
good questions by all.
Yeah. Mr. Denisha, Office of Aging Advisory Board.
Unless you want to hear the same report I gave.
No, we don't. I remember it well, and I do know we need volunteers, though. We can stress that one more time, because we do. Very important. And Youth Advisory Board, Ms. Terminelli.
Yes, sir. So our last meeting was on Thursday, August 27th via Zoom. And the bulk of the meeting really was about it's your task to wear a mask, mask designing campaign. So that contest closes tomorrow at end of business. And then our youth committees have a meeting on Wednesday of this week in which they will go through the mask designs that have been submitted for the quest, and then hoping to present maybe a top 5, a handful, to go to the Youth Advisory Board meeting on Thursday that then we could bring to you to show you what they've selected. And I'm sure that you've seen in the media this week, Cole Siebels, our youth committee president, was given an opportunity to do an interview, and that went really well. So some good PR for the youth board. Alexa's doing a fantastic job, really spotlighting some youth bureaus. So that's exciting news for us, especially with a new person in charge. So that's about it. I have our next meeting is, like I said, Thursday at 3 o'clock.
Thank you, Nicole.
You're welcome.
Any old business come before the board? Any new business? The executive session, we'll talk about it in the next meeting.
Yes, sir.
Good. First announcements, I'll do those as well in this next meeting. Okay. And there's no further business. We're gonna adjourn. We're adjourned.
Excuse me, I need to get been here too long. First off, I need to get a motion for the approval of the agenda.
We'll do that one too.
Mr. Forsythe, Mr. Reagan, all those in favor?
Aye.
Opposed? Thank you. Next up on the agenda is we have a presentation by our St. Lawrence County Forester regarding the emerald ash borer. Aaron, are you with us?
There, and John Penbush as
And
well.
John?
Yes, I'm here.
Yes, sir, Mr. Denisha, I'm here. Going to turn it over to you.
There was a PowerPoint sent over earlier today. I was wondering if I could get that up.
Coming.
Yeah.
On the way.
Thank you. All right, so this will be an update on the emerald ash borer and its current status in St. Lawrence County. Next slide, please. So the emerald ash borer is an exotic beetle that was first discovered in the United States near Detroit, Michigan in 2002. It is native to parts of Russia, Mongolia, China, Japan, North and South Korea, and Taiwan. It is believed that EAB arrived in the United States on solid woodpacking material carried in cargo ships or on airplanes through international trade. Next slide. EAB has spread far and wide to 35 states and 5 Canadian provinces since 2002. The movement of firewood and other timber products enables these beetles to travel further and faster than it can naturally fly. Since its arrival in the United States, EAB has killed hundreds of millions of ash trees, cost municipalities and property owners billions of dollars on treatments, removals, and replacement of ash trees. Next slide. EAB are species specific, affecting only ash tree species, and are very destructive, killing almost 100% of the trees that they infest. EAB larvae feed on trees cambium and phloem, which are the tissues that transport water and nutrients throughout the tree. So when EAB larvae damages these tissues, it causes the trees to starve to death. Next slide. So some signs and symptoms of EAB are canopy thinning and decline, the presence of epicormic shoots or water sprouts, blonding from woodpeckers feeding on EAB larvae and flecking off the bark, bark splits from larvae galleys lifting and separating the bark from the cambium layer, and then the distinctive S-shaped or serpentine galleries underneath the bark. Next slide. So EAB can naturally spread anywhere from a half mile to 3 miles per year, and this is dependent on ash density, EAB population size, and topography of an area. And ash trees typically die within 3 to 5 years after infestation, which is also dependent on EAB density, tree vigor, and site characteristics. So the map to the right shows the current known locations of EAB in St. Lawrence County as of August 1st of this year. And currently, EAB is naturally spreading at a rate of 1 to 2 miles per year in St. Lawrence County. Though this rate of dispersal could change if infested material is transported to new locations, so essentially the movement of firewood. So within 7 to 8 years, EAB could be widespread throughout the county. So to give you an example, EAB could reach the village of Canton in 2 to 3 years, and then ash trees would start to decline and die 3 to 5 years after that. So it could be expected to see dead ash trees in Canton within 5 years. Next slide, please. Here are some helpful resources that provide general information about EAB, some online resources to help with EAB management, such as determining ash treatment and removal costs, how to report EAB, and some more in-depth information regarding current scientific research and studies. Are there any questions?
Mr. Akers.
Yes, Aaron, so it seems like the ash tree will be demised. What do you expect? What species will replace the ash tree here in St. Lawrence County? What will take its place?
Depending on how it's kind of dependent on ash densities per stand. So, and then what kind of seed bank is underneath. Invasive species have a really high potential to take over just because they can outcompete all the other native species, and they typically occur where ash trees are, so that early successional species when they come up. In terms of climate change and soil temperatures, red maple will probably be a strong competitor, as they're the only ones who can withstand soil temperature increases. So I would assume red maple and invasives, unfortunately.
So the ash trees in China, some of the ash trees have developed immunity. Do you expect that to happen here in St. Lawrence County or in the United States?
Currently, there's a lingering ash project underway, and they're finding about 1 in 1,000 ash trees actually have some level of resistance. That being said, when EAB moves into an area, the density is so high, even those resistant trees can't survive that kind of impact. So essentially, after EAB comes through, kills all those ash trees, potentially you'll be able to see trees that come up that are slightly resistant after and potentially could survive after that EAB initial wave and populations are lower.
Okay, thank you, Aaron.
Yep.
Any other questions?
Burke's got a question.
Mr. Burke?
Aaron, you're continuing to work on the Emerald Ash Borer. Is that correct? Even though the offices are limited to in capacity?
Correct.
What municipality are you working with?
So we've actually have not stopped working as far as monitoring efforts. The EAB task force, which John Tenbush will talk about a little later, St. Regis Mohawk Tribe Environment Division, Franklin County Soil and Water, National Grid, DEC, USD, APHIS, FLEEL, PRISM, and the Forest Service have all continued their monitoring efforts, and they're actually helping us out in this area quite a bit.
Thank you, Aaron.
Legislator Haggard.
Thank you, Mr. Chairman. I have no idea. There are a lot of trees in St. Lawrence County. I have no idea what percentage are ash. Do you have any idea of how many trees are ash trees in St. Lawrence County?
So within the St. Lawrence River Valley, roughly, it's a little bit higher. So you'd probably be looking at 10 to 15%. Once you get within the blue line or the Adirondacks, you'd be looking at around 8%.
Thank you.
Yep.
Mr. Smithers?
Yeah, what are we doing or should be doing to, as municipalities or homeowners, to prevent accidents or damage from these trees suddenly falling down?
So one thing that has been actually completed in this past year was an inventory to see what the potential impacts would be on county routes. And an inventory was taken to actually help with planning purposes. As far as any specifics on that, the highway department is looking into what can be done with that information and how they can go about planning in the future to try and mitigate some of those hazards.
Anyone else have any questions for Aaron? I guess, Aaron, I know I was involved with the Emerald Ash Borer Task Force a couple of years ago, and we talked about the impact that it could have on some of our Native American craftsmen. Is that still a potential?
Yeah, so the U.S. Forest Service is actually working closely with the St. Regis Mohawk Tribe, and they are finding potential black ash sites that they can try and keep alive as long as possible so they can maintain some level of resource into the future. They're utilizing SLAM management, which is slow ash mortality. So they're putting in trap tree clusters around known black ash resources in an attempt to slow down how quickly EAB can infest those trees. They've also looked into preserving material, so actually taking splints, pounding them out, and then freezing them. They're getting about 20 years or so out of those for preservation. Another thing they're looking into is sinking logs in lakes, so actually taking oxygen aspect out of it and trying to preserve logs underwater. There's also alternative basket making material that they're looking into. Other species, I know they've tried box elder as far as that for splints, and they might actually look into older methods, even pre-black ash, which would be white oak, which they actually used to use way back when for splint basketry.
Great. Thank you, Aaron. I appreciate that.
Yep.
John Tenbush, I'm sure you have a part in this or some words that you'd like to share with us.
Yes, good evening. I was asked to talk about the history of the Emerald Ash Borer Task Force. Can you folks hear me? I'm getting a weird reverb. But if you can hear me all right.
Yeah.
Okay, fine. All right. Emerald ash borers have been a concern in St. Lawrence County for at least a decade. In 2010, the Environmental Management Council invited Mark Whitmore, an entomologist at Cornell University, to present information about the emerald ash borer, its potential effects on ash trees in St. Lawrence County, and how local communities can plan to deal with its impacts. This session was attended by more than 70 people. Most of them were involved in the forestry industry. A little later on in 2014, the EMC coordinated with Cornell Cooperative Extension, the DEC, Soil and Water, SUNY ESF Ranger School, and students from Madrid Waddington Central School to conduct a survey of ash trees within the village of Waddington. Now, the village of Waddington is about 1 square mile. The survey included trees that were found on public and private property. It was completed in 1 day. In a total, 483 ash trees were observed. 53 were seen as potential hazards, which means if they became diseased and fell, they might bring down power lines or hit structures or impede rights of way. Another 24 ash trees were observed to be distressed. They had broken branches, missing bark, or other obvious signs of distress. I mention that because we did another survey later, and I'd like to describe the differences. In 2015, the EMC coordinated with the Messina Nature Center and some of the partners from the earlier effort a year ago to survey ash tree resources and liabilities along the trails at the Messina Nature Center. In 2016, Don O'Shea, who is a resident of Ogdensburg and a member of the Ogdensburg Tree Commission and the vice chair of the Environmental Management Council, invited Paul Hetzler, who was a horticulture and natural resources educator at Cornell Cooperative Extension, and me, in my position as staff to the EMC, to make a presentation to the Ogdensburg City Council about the hazards presented by EAB. After that presentation, we felt that an ad hoc committee should be created to keep attention on the problem. And so we started the EAB task force. We've had a total of 40 meetings since 2016. Our current email list includes more than 50 persons. In 2016, we traveled to Syracuse to meet with the Onondaga County EAB task force. There we also saw the effects of EAB infestation. We were taken on tours of several neighborhoods where the trees were just decimated. We also prepared a map of highly probable areas in St. Lawrence County where EABs were most likely to be found. And in fact, the first EABs found in St. Lawrence County were in one of those highly probable areas that we had marked. It was along the St. Lawrence River in the town of Hammond. In 2017, we coordinated with, again, the EMC, DEC, Cornell Cooperative Extension, and Canton students to survey ash trees found on public property within the village of Canton. Approximately 80 ash trees were observed. Note the difference with the results found in Waddington. I bring this to your attention because a lot of the efforts that our communities are doing are to minimize the liability for local municipalities. They're looking at trees on public property. They're dealing with trees on public property, but there's a lot of liability out there for ash trees that are on private property. In Waddington, we found a total of 483 trees. And Waddington's a little tiny community. I have to figure that in Canton, there are a lot more than 83 ash trees. The lot more would be on private property. And those trees are going to be diseased just like the trees on public property. Those trees are going to be, dangerous, just like trees on public property. And as a matter of policy, we should try to figure out how we might deal with that. And I don't have an answer to that. I'm just saying that is a persistent problem. The EAB task force has helped partnerships develop between communities and organizations. Notable has been the willingness of National Grid forestry staff to work with local communities to address ash trees in their rights of way. Such activity has halved the cost and liabilities faced by those communities. If I'm not mistaken, National Grid has worked with the county, and National Grid is going to be dealing with ash trees on their rights of way, which is typically on one side of a road. That's why it halves the liability. So almost half, the county has 600 and some miles of roadway. So the left side or the right side of that roadway is going to be basically handled by National Grid. That's a heck of a partnership. Also notable has been the partnership with the St. Regis Mohawk Tribe Environmental Division. They have been active working on EAB issues. They have been out ahead of us, and we have learned a lot from them. We've also helped get EAB task force established in Franklin County, and we have provided direction to staff from Watertown and Jefferson County as they gear up to address EAB. Are there any questions? All right.
That's okay.
What's especially dangerous about this insect compared to other trees damaged by other types of insects in the way that the trees are apt to be killed and cause liability issues, like you said?
There are a couple of things. One is the relative speed with which the emerald ash borer kills the tree, 2 to 5 years. Another factor is that these trees, ash trees that are killed by emerald ash borers, and Aaron could probably explain the biology of this better than I can, but they're prone to what is called catastrophic collapse, which means they basically fall apart with no precipitating incident. There's not necessarily wind. There's not necessarily any kind of a storm. A tree just collapses and no warning. So that makes it particularly dangerous. And another reason is that ash trees, we had Dutch elm disease 50 years ago. We had chestnut 50 years ago. Ash trees were seen as a replacement for elm trees and chestnut trees in urban areas. So Aaron mentioned that in St. Lawrence County, the ash trees maybe 7 to 10% of the tree cover. In our villages, in our more settled areas, they can be up to 25% coverage in those areas. So that's 1 out of every 4 tree. That's a relatively large proportion of the tree cover. And so because they're predominantly in these villages and things, they are therefore closer to things that they could impact if and when they catastrophically collapse.
Does anyone else have any? Yes, Legislator Haggard.
Thank you, Mr. Chairman. Mr. Ten Bush, how would we mitigate this? I mean, is somebody going around checking these? Whose responsibility would it be to make sure that a tree isn't going to fall on somebody's head or their car or something? Would it be, as a board, what do we do?
Well, ma'am, as a board, I think the county is doing what it reasonably can in that they're working with Aaron and National Grid and others to do surveys of trees. And so the trees that Aaron has surveyed, he is able to, since he's a trained professional forester, he's able to rate trees. So he has an idea as to the degree of well, I don't want to put too fine a point on it, but he can't necessarily say this tree's ready to fall down now. I mean, but he can say that the trees, this tree or the trees in this area are further along the process of deterioration than in some other areas. And that gives us a direction to go. If Mr. Chambers sends a highway crew to take down a couple trees, he knows to go to this area rather than another area.
Okay.
And communities are starting to do some of that as well. The survey work that we've done in Waddington and Canton, the Village of Canton had their tree survey done professionally. The Village of Messina has had a tree inventory done professionally. Ogdensburg has had a tree inventory done professionally. Potsdam is having a tree survey done professionally of trees on public property. But again, as I mentioned earlier, nobody has been able to figure out a public policy solution to the problem of trees on private property.
Thank you very much.
Does anyone else have any questions or comments for either John or Aaron? Yep, I guess we're good. Thank you, John. Thank you, Aaron.
Yes, sir. Good evening, all.
Next on the agenda is Jason. We have a resolution authorizing the chair to sign accelerated transit capital reimbursement forms. Mr. Perkins and Ms. Curran. Go ahead, Jason.
Thank you very much. Good evening, all. The first resolution, as was read by Mr. Denisha, talks about additional funding that's been made available through the Accelerated Transit Capital Reimbursement Program, and these funds are going to be used to offset local match contributions for buses and bus shelters. And this resolution allows the chair to sign the forms to receive those funds.
Great, thank you, Jason. Anyone have any questions for Jason in regards to this resolution? There being none, all those in favor? Aye. Opposed? Carried. The next resolution, it's a resolution authorizing the chair to sign up to 3 one-year contract extensions with Volunteer Transportation Center, Inc. for first mile, last mile services. Ms. Curran and Mr. Fay. Jason.
Thank you. VTC has been our partner for some time for first mile, last mile, and they're really the only known provider that can provide for these services. DOT allows us to continue the contract with that entity for up to an additional 3 years, and that is our request.
Does anyone have any questions for Jason in regards to this resolution? There being none, all those in favor? Aye. Opposed? Carried. The next resolution is a resolution authorizing the chair to sign bus advertising agreements. Mr. Akers and Ms. Curran. Jason.
Thank you. We have a great partnership with our transit provider, and there is an opportunity to receive revenue from the bus wrap bus wraps that adorn a number of the buses that are that you see traveling around the county, and this essentially authorizes us to sign agreements to realize that revenue.
Great. Questions regarding this resolution? There being none, all those in favor? Aye. Opposed? Carried. Next resolution, authorizing the chair to sign a subrecipient agreement with the North Country Housing Council, Inc. for the delivery of the lead paint hazard reduction program. Mr. Forsythe and Ms. Curran. Go ahead, Jason.
Thank you. As you know, the HUD grant has had some significant startup requirements, startup tasks to get that project up and running. One requirement, however, that HUD does not have is for a formal subrecipient agreement. So at present, we do not have one. However, we would like to proceed and secure a subrecipient agreement with our provider, with the North Country Housing Council, because it allows us to just have a better understanding of the scope of work, the roles and the responsibilities, and identifies for potential conflicts of interest. We've used these successfully with the Housing Council for other grants, and feel that it would be an important thing to have for the lead grant as well, even though it is not a requirement. I think it's a good idea from a policy perspective.
Questions or comments to Jason in regards to this resolution? There being none, all those in favor?
Aye.
Opposed? Carried.
Thank you.
And Jason, next, would you give a discussion on the lead grant update?
Yes, happy to. We've seen some progress, and that's making us all here in the office and with our partners breathe a little bit of sigh of relief, because we see the ball rolling a bit now. We don't have huge numbers yet, but we have had 3 successful projects completed to date, which is great. We also have 14 applications that have basically potential individuals or potential clients, individuals that have gone through the initial vetting process. That does not mean that they will be a successful client, but it's the next step in getting them to that level. One thing that we are still finding frustrating or will present problems going forward is the incredible costs associated with some of these abatement projects. We have seen costs anywhere from the $60,000 to $70,000 range for abatement in some homes. Unfortunately, HUD only allows for a $20,000 allotment per unit. It is appealable though, and you can get up to $25,000. We have successfully appealed and have been able to do the project at $22,500. But as we go forward, looking at some of these projects that are in the $60,000 to $70,000 range, it's just not feasible for us to do those projects with this program. We're hopeful that we'll be able to leverage some money from another grant program, a state grant program, but that is still a work in progress in seeing how we can do that. But it is encouraging. We have some numbers, some completions. We have some numbers up. We need to find more projects that are within the price range where we can do the work and not have to step back from really expensive projects. We also have through the great assistance of Public Health, have done some rebranding a little bit of the advertisement. That always needs to be updated to keep it fresh, to keep the word getting out there in a different manner to get as much involvement, as much understanding from the public as possible. We have also included a lead program information at food distribution centers and sites throughout the county associated with the COVID crisis. So that's just another opportunity to get the word out. Yes, we continue to meet on a regular basis with our main partners, Public Health and the North Country Housing Council, and we are going to be moving to more of a more frequent combined meeting where we can all put our heads together, keep the ideas flowing about how to keep this project going forward.
Good. Questions for, questions for Jason? Jason, I guess the only question I would have, is the $20,000 or $25,000 figure that's attached to the grant, is that realistic?
Good question, Mr. Denisha. It's realistic in some parts of the country. What we find, we all know in St. Lawrence County, we have a lot of larger, older homes that are occupied by individuals that are certainly eligible for this program. They have children that may be affected by lead paint. They may, because of the age of the homes, they no doubt have a large concentration of lead paint. And it's when you have $20,000, you can do a unit in an apartment building. It's a lot more difficult to do a 3,000 square foot house that was built in 1890.
All right, thanks, Jason. That's about what I expected. Is there, no more questions? Very good. Thank you, Jason.
Thank you.
That way, on the Fair Housing Task Force.
Yes, thank you. Just a very quick plug for an event that's coming up this Thursday at 10 a.m. We have two presenters, Sally Santangelo, the Executive Director of Central New York Fair Housing, and Mrs. Griffith from the Legal Services of Central New York. They will be talking about the eviction process under COVID, and we've advertised it pretty far and wide for tenants, landlords, the general public, anyone that has any connection with tenants and leases, just as an information opportunity, just to see what's out there from the state and from the legal side of things with regard to the eviction process. So I do have a link that I'm going to share with anyone if people are interested in attending that. It will be recorded as well, so if you can't make 10 a.m. On Thursday, it will be available after the fact.
Thank you, Jason. Does anyone have any questions for Jason? Thank you, Jason.
Thank you. Have a good evening.
On to emergency services. Matt, are you with us? Yes, he is.
Good evening, everybody.
First resolution is a resolution authorizing the chair to sign a contract with New York State Office of Homeland Security and Emergency Services to accept a fiscal year 20 grant and modifying the 2020 budget for the Office of Emergency Services. Mr. Perkins and Mr. Lightfoot. Go ahead, Matt.
This is one of our yearly grants that we get fiscal year 20. What this does is for other fees and services, gives us money for our Spillman, our CAD maintenance, and the technical equipment that is going to help offset the cost for our interoperable equipment for our new towers that we're building.
Okay. Anyone have any questions for Matt in regards to this resolution? There being none, all those in favor?
Aye.
Opposed? Carried. And next one is a resolution authorizing the chair to sign a contract with New York State Office of Homeland Security for fiscal year 20 Emergency Management Performance Grant. Mr. Lightfoot and Mr. Sheridan.
This one here is another yearly grant. This one helps offset of administrative costs in the office, salaries of the administrative staff.
Okay, any questions on this resolution for Matt? There being none, all those in favor?
Aye.
Opposed? Carried. And the last resolution would be modifying the budget for emergency services for overtime costs. Mr. Fay and Mr. Forsythe. Go ahead, Matt.
This is to move $8,000 out of contingency into our overtime line to offset some of the overtime that we incurred that we're hoping that'll get us through to the end of the year.
Any questions? There being none, all those in favor? Opposed? Carried. And the last one, Matt, would be just a brief overview or discussion on the interoperability towers update, if you would, please.
All right, this is originally a 45-minute presentation, but I condensed it down to 2 minutes.
That's very, very, very wise. Thank you, Matt.
All right, first one we'll talk about is Governor. Governor is 280 feet tall, located behind the transfer station there on Route 11. The tower is pretty much 99% complete, power's on. We do have some of the equipment in the office. We did get some quotes for antennas and cabling to put this on. The only thing we're waiting on is the lights at the top of the tower to get hooked up, start up on the generator and the HVAC system. And then as soon as the contractor signs off, we'll be able to put the antennas up and put some equipment on. Hopefully it'll help us on that end of the county. Next is Wallington. Wallington is currently being worked on, 270 feet tall. As you see in the pictures there, that's the foundation and the round circles where the tower is going to sit. The big one's the shelter, and the other two is the generator pad and the tank pad. They're starting the steel. They actually started today setting steel. So I wasn't going to get a chance to get out there and get a picture of the steel actually going on today, but hopefully we'll be able to get that to you at some point. Completion date for this is October 31st. Hammond. Hammond's been our difficult one. That was the first one we started. We ran into a little bit of issues with some moisture in the ground. As you can see, the arrow in the back of the picture, that's where the discoloring of the soil was. So we figured there might have been some groundwater there. So being that said, we end up having to go back to Sabre. They are where we bought the steel from. They gave us the specs for the foundation. They had to redesign the foundation. It was originally 32 feet by 32 feet by 2 foot thick. There's 6 foot of dirt or soil on top of the foundation. Then the round piers come up and the tower gets attached. Because of the chance of buoyant conditions, they actually expanded the pad to 37 by 37 by 2 foot. So we had to do a change order for that extra 5 foot each way in the rebar and work up a solution where we can use the rebar that was already purchased on site. So we just had to do that. We're currently waiting for Midstate to send over. They sent us the change order over. And I asked him to sign a copy, send it to us so we can get it signed and we can get the guys mobilized on the site and get going. Kimball Hill, just a quick one. This one has been done. As you see, there's 2 towers. The one on the right is the newer one. There is some stuff on the one on the left. We're trying to get all our stuff off there and some of the vendors off on the new one. Currently, we have 2 electric bills and 2 heat bills. We want to condense that down to 1. There's no reason to keep them both going when we only need the 1. Cranberry Lake. Cranberry Lakes, we just recently had some issues. That, as you see, is the tower is owned by American Tower Incorporated. That is basically an AT&T rents most of the space. We do have a repeater on the site with a small antenna. Some of you know AT&T got permission to turn up some of their signal strength. By doing that, it kind of shut that repeater down. We're not able to transmit off of it. So right now we ended up moving them to Mount Morris. Mount Morris is in Tupper Lake. It's a little bit further away on Big Tupper, but we're able to hit the repeater. We're able to tone them out and the pagers tripped and the sirens tripped. So we are currently working with Blue Wing to come up with some solution for the Cranberry Lake area to be able to get something more permanent in that area. And we move on to Big Tupper. This is one of our repeater sites, repeater 8. You can't really see, but right there is our little itty bitty antenna with 2 little loops on it. That's ours, this directional point towards our side of the county. Any questions, comments, concerns? Thank you very much.
Any questions from Matt?
You know how to take questions right there.
We lost. Thank you, Matt. John, did you have a question?
Yes, and it doesn't have to be answered tonight, but I would like an update on our attempts to market the space on the towers.
We currently are working with one of the vendors for one of the sites. The county attorney has a tentative contract. Ruth and I have already met last week about it. They're waiting for an update, so there will be some updates. We are moving forward with that. One of the things, the concerns we do have is over this happening in Cranberry Lake, we don't want to, if a cell phone vendor does come on one of the towers and we end up with a lot of interference, we got to be able to them turn it down or get off or something. So those are things that we're working up, but we are making progress with that.
Good, thank you.
Any other questions? Thank you, Matt.
Thanks, guys.
Next on the agenda is Tim. We have a resolution declaring October Domestic Violence Awareness Month. Mr. Forsythe and Mr. Reagan. Go ahead, Tim.
So this is a yearly resolution I put forth on behalf of the county's Domestic Violence Task Force, seeking you guys to declare October Domestic Violence Awareness Month. This year's theme is Seek Justice, Enforce Victims' Rights, and Inspire Hope. Because of COVID and social distancing, they won't be doing their table in the lobby of the house, but they're going to focus more on some media attention. But other than that, that's it.
Questions for Tim on this resolution? There being none, all those in favor?
Aye.
Opposed? Carried. Thank you, Tim.
Thanks.
And Mike.
Okay, the first resolution is just moving some money around our central stock room. No increase. Oh, I'm sorry.
Ever a resolution modifying the, I know you want to get out of here, Mike. Resolution modifying the 2020 budget for the Governmental Services Department for COVID-19 response. Mr. Forsythe, Mr. Fay. Okay, Mike.
Okay, thanks. No, it's, we're just moving some money around the central stock room accounts, no increase in local costs, just so we can pay some of the appropriations we did for sanitation supplies for the COVID response.
Any questions for Mike on this resolution? There being none, all those in favor?
Aye.
Opposed? Carried. And the next one would be a resolution regarding adoptions of records retention schedule. Mr. Perkins, Mr. Akers.
Okay, the New York State Archives is responsible for providing records management retention schedules. The responsibility of the county is to adopt these so we can officially dispose of records. Recently, the State Archives has combined all of the different ones for the counties, villages, school districts into one, which is now called LGS1. There is a copy of that on Google Drive if anybody would like to review it or look at it. And this resolution just adopts this as required.
Any questions for Mike regarding this resolution? All those in favor?
Aye.
Opposed? Carried. Thank you. Thank you, Mike. And Johnny.
Should be here. Hello there.
There she is. Okay, we have the first resolution is authorization to revise Medicare Part B reimbursement policy for St. Lawrence County. Could I get a motion, Mr. Forsythe and Mr. Sheridan? Go ahead, Johnny.
So in 1985, the Board of Legislators established a reimbursement policy for retirees and their spouses for Medicare Part B premium reimbursement. And in 2012, the Board of Legislators adopted policy changes related to eligibility and reimbursement levels. And if you recall, last year, at the end of last year, we had a larger number than usual of retirees that did not provide HR with the documentation needed by the deadline prescribed in the policy to receive the Medicare Part B reimbursement. So after about the third retiree calling to ask about the retro reimbursement, I brought the issue to the board chair, and at that time we decided we needed to bring it to the issue and the policy to the full board to discuss and possibly revise. Our discussion at that time led me to believe that there should be no deadline for reimbursement and no documentation required. The county treasurer feels it is important to have both in place. So I've revised the policy to expand the timeline for required documentation from 6 months to 12 months, and to reduce the number of reimbursement payments from 2 to 1 a year with a deadline of November 15th. I believe the revised policy was provided for your review, and I don't know if Dave Forsyth has anything he wants to add to this, or if there's any discussion about it.
At 7 o'clock, I would've. No, I'm good, Jenny, I'm good. You did good.
I know everyone's, it was included with the packet. Does anyone have any questions regarding this resolution? There are no questions. I would just comment.
John's going.
Okay, John, Mr. Burke.
That having a deadline once again would mean that people beyond the deadline, we'd be faced with the decision of not reimbursing them. Is that correct?
Yep. So this policy revision just ends the deadline. It gives them more, it moves it from 6 months to a year deadline, and actually almost a 2-year deadline when all is done and said. It could be a 2-year deadline, but that was just, and the only reason I didn't take the deadline out completely is because the treasurer really feels that there needs to be that deadline and that documentation as well.
Just a follow-up question. Would we have a chance to, I assume that we would have a report for anybody who is going to lose reimbursement and be able to talk about it at the time? Is that correct?
I can certainly bring those issues up now. Absolutely. One by one as they come along.
Thank you.
Sure. Yep.
Thank you.
Any other questions? All right, all those in favor?
Aye.
Opposed? Carried. The next, actually there's the next resolution, actually there's B and C, but actually they're the same, with the only exception being the phase-in time. So I guess the resolution authorizing change to retiree pharmacy prescription copays and directs the Human Resources Department to adjust retiree prescription copays to keep pace with CSEA union negotiated pharmacy copays for active employees. And Mr. Forsyth and Mr. Lightfoot. Johnny, you want to talk about this, please?
Sure. So for several years, Lawrence County utilized the retiree drug subsidy program offered by CMS, which reimbursed healthcare plan sponsors, us, for a portion of eligible RX expenses, which enabled St. Lawrence County to obtain more generous drug coverage for retirees while keeping copays at low levels. In January of 2016, St. Lawrence County switched from RDS to the Employer Group Waiver Program, which is termed EGWP, which provided increased benefits like catastrophic high-cost RX protection and saved St. Lawrence County more money in prescription drug costs. I believe this is one of the reasons why RX copays were not increased over the years, with the other one being the coordination of the timing of the change. So for a retiree RX, for retiree copay changes, they can only be done on January 1st of any given year. And there also has to be a 90-day notice to CMS. So I believe those two factors played in the role of why St. Lawrence County retiree RX copays started lagging the active employee population, and that was as early as 2010. So this came up a while back, and somebody, you guys were wondering what happened, and that's what I believe happened. So the Healthcare Committee has recommended increasing the retiree RX copay to match the active employee population, and the current rate differences are between $8 and $20 per prescription, depending on the tier. And so I have prepared 2 resolutions for your consideration tonight. And one moves retirees to match CSEA rates effective 1/1/21. And the other moves them incrementally a $3 to $5 increase over the next 4 years to match CSEA rates by January 2024. And the reason I put up both of these is because I recall this discussion a couple years ago when it was on the board floor, and there was some interest in a phased-in approach. But the healthcare committee wanted me to bring both, just for discussion purposes and preference. I don't know, Dave, if I've missed anything or if you want to add anything.
Any questions? Ms. Terminelli?
Johnny, can you just define what you mean by lagging? It says that the retirees started lagging the active employee population.
Yeah, so the retirees co-pays right now for generic are $7, while for the CSEA active, they're $15. For the retirees brand name or formulary, they're $15, and for CSEA, they're $35. And then for the non-formulary, they're $30 for retirees and $50 for the active population.
Okay, so is the reason in the past that the retirees prescription, the copay prices, sorry, there was a lot of extra noise there. Is the reason in the past that retirees haven't seen an increase in their copay? Would that have been considered because maybe they were on a fixed retirement income that didn't get raises and other things? I'm just wondering if a third option is to not choose either of these.
So that's definitely a third option for you. But I believe that the reasons were because we had these Medicare, these CMS programs that were in place that allowed us to get these subsidies, that allowed us to keep the retiree rates down. In fact, the first program that we were in, that was part of the program that they gave us subsidies to do that specific thing, keep those rates lower. And then the second one was, in 2016, we switched over to a new group, and that's because it offered more benefits for the retirees, and it kept the drug prescription costs down as well. And so I believe those 2 reasons that's one of the reasons why we kept them lower. The other one being the coordination of the timing of it. So like we just finished CSEA contract negotiations in March, so we couldn't have changed the retirees at the same time because we have to wait until January. So I think that there was that playing into it as well. And there might have been another thought that, yeah, we should keep these lower because they're on a fixed income, and that I wouldn't know. I don't have that history.
Mr. Burke?
Johnny, what's the recommendation, or Dave, what's the recommendation of the health committee?
The recommendation was to follow the CSEA guidelines. It's just, do you want to gradually work it in, or do you want to do it all at once? The only thing I'm concerned with a little bit with it, are we going to be able to make the 90-day for 1/1/21?
So what I would suggest is that if the kid tonight determines that they want to make some kind of movement in those RX, then I can tell PROACT and tell them now, tomorrow, and we'll have the 90 days in. If you feel comfortable at the full board meeting, there wouldn't be any change in your thought processes.
Well, I bet there'll be more people here than at this meeting for sure, but I have no issue either way. It's just however the will of the board is. I think it's right. Medicare does it every other year to individuals, so, right is right, I think. That's my opinion.
Mr. Terminelli?
sorry, and I'm not well versed in this kind of stuff, but it just seems to me, I know, like as an educator, right, when we negotiate our contracts, we very much like to keep in mind the retirees and knowing that there's always going to be a cost of living adjustment for workers, and that there's always going to be raises that are calculated for current employees, and knowing also that the employer, when they're budgeting, takes into account those forecasted costs that they're going to incur by both their current employee benefit packages, but also the employee or the retired packages. And I just have a very difficult time. And I know to us, we might look at it and just say it's $5 here, $8 there, but the older American population actually sees the highest cost associated with almost all of their prescriptions. And so I think that it's difficult to push out a cost to somebody that's living on a fixed income and is not getting raises just out of the blue. I'm just a little concerned about it.
Other comments, questions? Legislator Haggard.
I may or may not be one of these older Americans that Ms. Terminelli is talking about, okay? So if the choice is we have to give them an increase, we're choosing between all at once, which I would be totally opposed to because that's going to shock them, or phasing it in, which I would go with. But I'm assuming that what Nicole was sort of referring to was not on the table, and that is absorbing the cost. We can't do that. Is that correct? Either Johnny or Mr. Forsythe?
As far as I'm concerned, it's up to the will of this board, so I know how I stand on it, but it's gonna take 8 votes one way or the other. So it's not an easy issue, no question about it. So.
Okay, that answers my question. Thank you. Johnny, did you want to say something? Okay.
That's an option that's out there for sure. I mean, you guys can just say that you don't agree with the resolution and you're not putting it forward, so.
Thank you very much.
Well, I guess that is an option. So how would we go about this, Ruth? We obviously we have to choose one of these 2 resolutions to increase the copay for retirees, or we don't act on the resolution. Mr. Akers.
Mr. Chairman, I would make the motion that we accept the resolution, which includes the proposed retiree phase-in.
So you're making a motion to, that we accept the second, the C.
Phased in.
The phase in over 4 years. And Mr. Lightfoot, you're second that motion. Okay, we have a motion on the table. It's been seconded for the resolution. That's actually would be the second one. It would be the phase in over 4 years. All those in favor of that resolution?
Aye.
Are you having a discussion first?
No.
Is there a discussion?
We can, John?
That's the way it's supposed to.
Well,
if that's what you like, that's what we'll do.
That's not what that's how it's supposed to work. Motion, then discussion.
That's better at 7:30, Tony, than 10:30.
Our new parliamentarian.
Larry,
Yeah, go ahead, John. Yeah, go ahead, John.
Since since the proposal, the motion on the floor is to do the phase in, I mean, we're under no timeline now. Is that correct? I mean, we don't have the 90-day timeline. if the vote carried and went with that, we don't have the 90-day timeline. Is that correct, Johnny?
So I would, what I was hoping to do is if this committee felt that you were gonna make a decision to make the movement tonight and that you felt it was going to go forward in the full board, then I would I would tell them tomorrow so we hit the 90-day timeline. We can always back out and say, well, you know what, we're not doing it. But I could meet 90-day timeline by tomorrow.
For my part, I'd like a little bit more feedback from the people or the union, the people that represent the retired. I'd like just a little more information before I weigh in, and if I'm forced to vote on it tonight, I wouldn't vote to support it.
Mr. Denisha,
Mr. Latham.
those that are retired are not represented by the union.
No kidding.
That's true, Joe, but the union has a closer finger on the pulse than most of us do.
Mr. Akers.
So I would urge that we move ahead on this. As you read in the resolution, the lagging has started as early as 2010, which is 10 years ago, and 2013 for other groups based on this. On the contracts that we have settled, the healthcare is the same for this year, and all the contracts, the increased contribution occurs in 2021. So this would coincide. My preference, John, would be to actually put in the full amount, but as I'm getting older and getting closer to that age of 65, I'm thinking maybe I'd like to phase in myself. So I think this is a compromise. I wish that the committee had submitted one or the other. They did not, out of respect for the wishes of the board. So I think we need to make a decision tonight on the resolution, whether we want to do a phase-in, table it, or the other. So I'm recommending this one here where it's a phase-in. I think it's fair. It allows for changes, gradual. Thank you.
Any other comments? Discussion? On the resolution? Okay, there being none. All those in favor?
Aye.
Let's do a roll call vote, please.
This is a roll call vote on the second page, second resolution.
Yeah, phase in.
Phase in.
Okay.
Akers,
Yes.
Kay,
Yes.
Haggard,
No.
Piacco. No. Burke,
No.
Arquette,
No.
Terminelli,
No.
Reagan,
Yes.
Forsythe,
Yes.
Lightfoot,
Yes.
Sheridan,
Yes.
Smithers,
Yes.
Denisha,
Yes.
Wickens,
Yes.
9 yes, 5 no, 1 absent.
Motion is carried. Bruce.
So moving on next to the Vacancy Review Committee, we have Amy Dona with us this evening. She will speak to the position for Assistant Conflict Defender. Hi, Amy.
Hi, how is everyone? So I'm asking to fill the Assistant Conflict Defender position. It'll become vacant October 1st due to a relocation of one of our employees to New York City. This employee primarily handles the family court, a family court caseload. All the attorneys in our office have family court and criminal court caseloads. But this attorney primarily handles a lot of the neglect and abuse matters. A lot of the cases are scheduled for trials and hearings coming up, so it's very important that we're able to fill this position so that we can start reassigning within the office, which we're doing, but also have full staff again. The local courts have been reopened as of August. We're doing virtual and in-person court appearances in all the courts now. So family court and county courts in person as well as virtual appearances. Local courts are still in person, and we do have coverage issues for our office. Filling this position, we'll still have some coverage issues, but really we just need to fill this position. So I'm just asking to approve that.
Any questions for Amy? Okay, thank you, Amy.
Thank you.
And the second department we have this evening is Sheriff's Office. Sheriff Big Ward.
Good evening, or good night, or whatever time it is right now. For you hockey fans, Tampa's up 3-2, just so you know.
Yeah.
There you go. So I have 3 vacancies, 2 in the jail, 1 on the road. I have 2 positions that have come open, 1 from resignation, and 1 from retirement. 1 retirement has been since August 11th. The second just came vacate a week ago. The New York State Commission of Corrections, it's 56 mandated staff. The 2 leaving brings me down to 54, so I need to fill these 2 just to maintain the New York State staff. The road patrol position, an 8-year officer's decided to leave law enforcement for many different reasons. He's going into business, believe it or not. I don't know if that's good or bad, probably good. But I need to fill that position. I have a prospective candidate right now, so that'll save obviously in cost of academy and training if we can get that person to lateral over. So I'm looking to fill these 3 positions.
Questions for the sheriff? Jail count, Sheriff?
92 and growing.
Any other questions? Thank you, Sheriff. Oh, John's got one.
Go ahead, John.
Brooks, just not for tonight, but wondering if we could get an update on the that 201 regulation that came down from the state, that all the police departments had to come up with a plan. Just wondering if you could give us an update. And again, not tonight, it's late, but maybe the next time.
So just briefly, because I talked to the county administrator about this today. I'm meeting with the chiefs Wednesday to talk about this. Each municipality has to have a plan. The counties have to have a plan. My plan is for the county end of it is to have 4 county forums throughout the county. I'm trying to get Norfolk as 1, Hewlton as another, Edwards as another, and Parrishville Colton area. So I could kind of hit 4 corners of the county where the public don't have to travel very far. They can come and speak. I'll do a PowerPoint presentation for you guys, but a little more updated. But after I talk with the chiefs on Wednesday, I should know a little more. But I am planning in October, November, having public forums, and that's a part of the executive order that has to be fulfilled. Other than that, just to let you guys know, and I let the county attorney know this also, our agency just got accredited last week. We passed through the state, which is a big feather in our cap. I'd like to thank the undersheriff and Deputy Leighton Filiatra, our accreditations manager. They put a lot of time in, along with our other road patrol officers, to make this happen. Part of that accreditation, accreditation really fills a lot of the boxes for this new executive order, John. So being accredited is huge. Ourself and Canton PD are the only two law enforcement agencies in the whole county. They're accredited. The standards are very high. There's 103 standards that you have to meet, or you don't get the accreditation. So we're really checking a lot of boxes with our accreditation. But the forums coming up in October, November are really what needs to be done.
That's great. Thank you.
Thank you.
Yes,
Legislator Haggard.
Just a quick follow-up to what John brought up. Sheriff, I did have the pleasure of speaking to the undersheriff about this. I don't know if he passed that along to you.
He did.
Great, that's good. So there will be people in the communities involved, not just from these like town halls, but actually working on policy and stuff with you.
Well, yeah, I mean, I don't know if you're saying working on policy. I would say they have input in the policy.
Right.
But
That's what.
Yeah, they'll have some input. They have input. We want them to have input. But like I said, our policies are really already there for, if you read Executive Order 203, and it's quite extensive. It's like 120 pages. But we've already accomplished, as in many sheriffs of the state have already accomplished many of these conditions for the executive order. The part that really needs to be, as I said, needs to be accomplished is these public forums and their input. And I've got, I don't know, I've probably had 8 to 10 people that have already called me personally and said, I want to be part of it, which is great. More the merrier. We want to see a lot of input from the public, different perspectives, different people. Yeah, we're going to take all their input and make sure we're fulfilling the executive order.
Thank you very much. Thank you.
Any other questions for the sheriff? Thank you, Sheriff.
Thank you.
Thanks, Sheriff.
Okay, so I will move through the items I have to report out to you this evening. I will begin with the letters on your agenda, and then I will move through quick updates. I have transfer of funds for you and about 4 items to give you updates on and wrap that up. First item tonight is the review that was requested last month with regard to DSS legal. And I can put it in these terms. There are 5 of each. There's approximately 5 requests being made. There are 5 actions already being taken, and there are 5 recommendations to consider. So I'll walk down through them quickly. The 5 requests, and these are a compilation of what I've received from Cindy, and certainly a number of things that many of you have been contacted about. There's been a request with regard to the increase in workload and presence in court, both as a result of returning from COVID, as well as having many parts of the family court to present to. So there's been a request for additional attorney staff, additional support staff, increased salaries for these attorneys, to contract out the appeals work. Currently there are 22 pending for the Department of Social Services, and to have support matters managed by the county attorney's office. So those, in summary, are the requests. Actions that have already been taken include the supervising attorney grade and title, so that would mean an increase to salary, has already occurred. A promotion of social services attorney to the senior position of social services attorney has also occurred. The compilation of the social services attorneys that were vacant for a period of time. One has been filled on September 8th, and the final current position will be filled tomorrow, September 22nd. So after tomorrow, they will begin the process of onboarding a complete staff of the existing positions in DSS Legal. There's also an intern program with one current intern on reporting to assist in the department with a current practice order in place and a bar exam scheduled, as I understand. As Cindy mentioned when she was present with us this evening, and she certainly is here as well, she's also taken up weekly meetings scheduled on Monday mornings with the supervisors of Children's Services, Child Protective, as well as Legal, in her terms to look at the process, to continue moving cases through, and to make sure that things don't get caught or hung up in the process to move them through. So with the knowledge that we have at the time, they can prepare accordingly. Now on to the recommendation. As mentioned, I'd like to recommend securing the full complement of attorney staff. As I mentioned the dates, they should be at full staff by the end of this week. And review the gaps that remain after they've had an opportunity to work together, and to also move into the post-COVID court appearances that are occurring now. I would also recommend that either one additional social services attorney be added, or that they contract out the appeals work. In the research that Cindy provided to me, there are 2 counties that contract out the appeals work. And as far back as we can tell, the appeals work has been completed by one attorney in the office. So I would present that as an or scenario at this time, that either they could have a contract put out to obtain those services and a resolution be approved by the board to sign a contract, or they could opt to hire that 5th attorney at this time. The next recommendation would be and this would be to look at this for 1 year if the contract for appeals was the option, to contract that out for 1 year and make a determination based on the staff if in fact they could take that work back, or if it best be outside the county with a contract attorney. The next recommendation would be with regard to support matters. For 1 year, authorize a contract with the county attorney's office so that the work being done by the county attorney's office could be reimbursed by the state. And again, after 1 year, evaluate that option to determine if that work at that time could be taken back, or if it best resides in the county attorney's office. The next recommendation I would make is one that's extended to attorneys on staff already, though these attorneys are in the district attorney's office. Consideration currently for social services attorneys, so this is not for the senior or the general counsel. Currently, they exist salary-wise in band 4. What we offer in the district attorney's office is a balance between band 4 and band 5. Let me tell you what that means. Currently, the social services attorneys can be hired between a range of $63,000 and $81,000. This would allow that base to remain the same at $63,000, but it would give the opportunity upon a human resource review of training and experience for the opportunity for the top of band 5 to be $90,361. Now bear in mind, the senior social services attorney is also in band 5. So with the expectation that that person, that position would supervise the others, they would always need to stay ahead of that position. And then finally, in 2021, include the net difference. As you've heard many times, this position, any of these positions in social services do have reimbursement attached to them. So include the net difference in the contingency account, which approximately at the rates we're working with right now would be $20,868. So that once that review is conducted, after full staff has been achieved and they've had a period of time to work together, and on my indication by the end of this year, we identify those gaps and we have funding should it be warranted to add another position. What I will do is send all of the recommendations, the current status of request, and the actions already taken to you by email to review. I would also just mention that the current number of children in foster care, Cindy might have mentioned, was 311. There are 26 children in institutional care. And just by way of the expense associated with that, the $1.1 million accommodation you made this evening for foster care has already spent, pardon me for not having it right in front of me, So far this year, $2 million budgeted. They've spent $2.5 million, and the 1.17 was modified at the committee level this evening to deal with the foster care expenses. Last year, we spent $3.39 million for foster care. The year before, 2.1, and most of the years going back to 2014, we spent approximately 1.6. So those are numbers that you can see a dramatic increase. I'm also working to get, and for many years, this office tracked the number of cases which they can be referred to in a variety of ways. What I can tell you is the numbers that we're looking at now in terms of child welfare orders are up at least a third. What I can also tell you is in child support, almost double. Certainly, we are at the top of one of the lists that we prefer not to be at the top of, which is the volume in family court, I believe, is the top in the state. From that perspective, Cindy did speak to the ability to prepare. However, if you're told today that you need to show up tomorrow, I'm not sure 10 bodies are going to help. What I'd like to do is be able to bring these recommendations back, send these to you so that you can process these as I've mentioned tonight, and then I can add a discussion item on the finance agenda where we can revisit these and any questions that you may have. I'll take any questions now or at the end of my report. Doesn't matter to me.
Mr. Burke.
Ruth, Cindy had mentioned that she had done some benchmarking with other DSS commissioners. And I guess, you know, when you ask us to make decisions, I mean, there are certain pieces of information that stick in my mind. The ratio of 50 to 1 for children in placement, which would mean if we're at 311, that would be a little over 6 staff attorneys or 6 attorneys. And again, you know, I think it would be helpful for all of us to have the benchmarks shared with us. And as we talk about foster care, doesn't it, and again, correct me if I'm wrong, but doesn't it seem that if we don't have the capacity to process children's cases through courts, does that not mean that we may have foster care expenses that aren't needed? And again, I'm by no means an expert on this. I try to grasp what I can grasp, but it would seem to me that our best option for protecting children and for not having lengthy foster care is having a system of court action that is highly efficient.
John, I believe that's one of the aspects of it. I also believe that looking at how foster families are interacted with in terms of our caseworkers, which is certainly something that the board has been supportive of addressing in the past 18 months. I think there's a number of aspects that Cindy is taking a look at more carefully. I think her background's helping take a look at some of the important factors associated with that and the organizations that we work with associated with that. 4 counties, just in terms of comparative data, were provided with regard to this. Each of those counties have additional interaction with county attorneys, but in the classification of St. Lawrence County, which is classified as a large county, our neighbor, Jefferson County, has 12. However, they have county attorneys included in their total staffing. So that makes it a little bit challenging. You know, when we look internally, I know that there is sometimes an interest in seeing these numbers, but also it's important also when you look at other considerations that may need to be made. The attorney percentages, we have 27 staff attorneys. There's 15% in each DSS and our conflict defender, and roughly 37% of our attorney staff in the public defender and 34% in the district attorney's office. As I mentioned, there's also an additional request for support staff. DSS support staff has 1.5 to each attorney. The conflict defender has 3/4 of 1 to each attorney. The public defender has 4/10 of 1 to each attorney. And the district attorney has 0.6 to each attorney. So the value of the fact that 2 of those offices handle family and criminal while the district attorney's office handles mostly criminal, and certainly DSS handles mostly family court. So it's a challenge. Certainly we can look at what those benchmarks are. You know, when we look at medium-sized counties, one county has 17 staff members, another has 7. And then another neighbor we often compare to is Oswego County, and they're considered a small county with 9 staff, and we have 10.
Well, again, Ruth, I'll just say, this is my 2 cents, so the rest can take it for what it's worth. But when we had 4 attorneys when we had 155 kids in placement. We are about to have 4 attorneys when we have, I think you said 311 cases. So the staff assigned to do the task, which is in social services, is, I guess if you were to look at the numbers, you would have to wonder if it's commensurate with the tasks that they are expected to complete, and that's a concern to me, because I think we kick the can down the road when we don't adequately staff an important function like that. I think that it costs us in many other areas that we are now seeing, such as foster care.
Understood.
Mr. Akers.
I just want to commend our county attorney, Mr. Button, because he went in and he cleaned this mess up on his own. And I want to send my appreciation for the work that he accomplished in that time period.
Well, I need to say something about that. Not express gratitude to Steve, but Steve went in when the COVID was going. You know, how many cases did Steve try? So if we're going to say that it was cleaned up, there were still many cases that it's when the floodgates opened up, Steve was already out of there. Steve was out of there when the floodgates opened, and the judge demanded to have a whole bunch of hearings. So let's give credit where credit is due, but let's not shower it where it's not due.
All right. Moving on.
I would just mention that we are going to be speaking with Hammond, but we will not at this time be putting forward a resolution for you to request the alternative boundary. I don't believe that I observed there to be a comfort level moving forward requesting this, but we certainly will have more conversations with the local municipality and bring that back to your attention. Okay? One transfer of funds to report out to you pursuant to local law C for the year 2011. $3,905.69 was transferred in emergency services with grant money used to pay for Verizon and Spectrum with some of the projects that you saw this evening. Quickly, I will give you a COVID-19 update. There have been 51 reports in the enforcement side of the house since September 1st. We are over 2,000 since March. The EOC, the Emergency Operations Center, officially closed 9/17, so that was last Thursday. They were open for exactly 6 months, and certainly if the numbers spike or if there are storm events that we need, we will stand up the EOC as required. And in the report on the scene of this evening, that is the backup 911 center that was made reference to in Harrogate Commons. We did work out of there and out of the Court Street location during COVID so that you know, for social distancing purposes. It also gave us a great opportunity to make good use of it and work out any concerns associated with having that operational for multi-days and weeks at a time. The work group continues to meet weekly, prepared to increase the frequency if the case numbers change. The reopening task force meets as necessary to get information out to the public. You've seen the navy blue signs. Also getting press releases out at this point about returning calls to public health, making sure accurate information is provided, but also continues to discuss the impact on businesses as we reopen and as we continue to move through that process. Public Health has hosted the municipal and the college call every other week to inform. That is a great call if you have the opportunity at 9:15 on every other Thursday. Internally, we've remained at 3 positive cases among staff since March. Precautions continue to take place, and there have been a few others that have been quarantined, but there's no known exposure. We continue working to make sure staff are safe and that 100% of the work gets done. I did have the opportunity to ask Alexa. There are 12 mask designs submitted so far. So if you know of anyone, they have till tomorrow to get those in. Next Tuesday was the date that the responses that are received for the Smart Path update could attend. I have 3 legislators that can attend at this point, 10 a.m., and I'll send you the details. They'd like to meet downtown at their office and then take a tour. So if anybody else, I'm gonna let them know by Wednesday. If you could attend, please let me know. Tonight's presentations will be located on Google Drive so that you can peruse those following the information provided. And at Finance next week, I will bring to you a contract request for approval for Drescher and Malecki to remain as our auditors for the next 3 years with 2 one-year options. So I have those prices as well. That's all, unless there's questions.
Anyone have any questions of the county administrator? Pretty good, Ruth. Thank you. On to committee reports. First one, Ag and Farmland Protection Board. I have nothing to report other than our next meeting is Thursday, October 1st, and there's a continuing concern about solar arrays being sited on prime farmland. Next on Alternatives to Incarceration Board, Mr. Burke.
There have been no meetings, so there's nothing to report.
Emergency Medical Services Advisory Board, Ms. Curran. She's gone. Okay. Environmental Management Council, Legislator Terminelli.
So in lieu of our meeting last week on Wednesday, we had an alternate plan to attend the St. Lawrence River Watershed Management Plan public meeting. That was just a webinar type of a meeting. I believe it was their 3rd and final of these, and they were for public questions, concerns on the draft proposal that must be submitted, I believe, by the end of the year. So they just shared the information that they had found so far and what they were planning to report or include in that report for the watershed management plan. Just to note that when we say water management plan, it's really a gathering of a lot of data, looking at challenges and things like that. And really what it can be used for is further down the road to look for funding grants. They're hoping that communities can work together to address challenges and just a common language for future development of our natural resources in the watershed.
Thank you. Fire Advisory Board, our last meeting was Thursday, August 20th. We have a new, actually Rick Collar, who was CARS 22, is retired. He's been replaced by Dave Weitz from Waddington, who's a new District Deputy Fire Coordinator, CARS 22. And there was some discussion around fire prevention, actually from the Office of Fire Prevention and Control, with the fiscal constraints and the COVID-related restraints, that there was some difficulty with providing training opportunities. And next meeting is Thursday, October 15th. Jury Board, Mr. Sheridan.
The jury board is not met.
Planning Board, Mr. Fay.
I'd just like to add what you said on the Ag and Farmland Protection Board, that the planning board is worried about prime farmland also, and we recommend on numerous occasions to the towns that you do not like them on prime farmland, but the towns or villages can overrule us, the majority plus one.
That's unfortunate. Okay, does anyone have any old business at this point here to be brought forward? Any new business? Mr. Forsythe.
11 o'clock at night, I get a little frustrated, I guess. Tonight, several instances that I've watched where we had people speaking, department heads speaking, and members of this board texting constantly, not paying attention to the speakers. And you know who you are, you're still doing it. I think it's disrespectful, and I'm just ashamed to be part of it. It's ridiculous, so. Just my thought. To me, it's ignorant behavior, but thanks.
Just wanted to say that Tom Plastino has passed away. I noticed it, there was no notification from legislative group. I don't know if everybody knew that, but he passed away last week.
Thank you. Thank you. That was old business.
No,
that was new business.
That was new.
Okay, that was new. Is there any other new business come before the committee? There being none, do we have need for executive session?
I think we could just do appointments if that's okay.
That would be wonderful.
Everything else will keep.
So we do have need for executive session for appointments only. And motion to go into executive session, Mr. Akers and Mr. Forsythe. Motion to adjourn. All those in favor?
Aye.
Done.